Welcome to part one of our key terms deep dive for Headmaster Test Prep. You have finished your training. Congratulations. Now it's time to translate that knowledge into certification success.
Absolutely.
There are 10 parts total in this series, one for each major chapter. Stick with us to ace your exam.
And we know you've just wrapped up your nursing assistant course, your textbook. It's probably overflowing with facts, right?
Oh, yeah.
So our mission today is really laser-focused. We're tackling the core vocabulary, the absolute essential words for the written Headmaster test.
Exactly.
And we're really going to dive into those concepts that pop up all the time on the exam. And, the ones that candidates historically miss quite a bit.
The tricky ones.
Yeah, the tricky ones. Things like hypo violations, understanding your scope of practice, the definitions of abuse. These aren't just definitions you memorize. These are the actual legal and ethical lines you'll be tested on.
That's right. And this deep dive, it's really set up to make those foundational terms stick. We want to immediately put them into real-world situations, those high-stakes scenarios you might face. So we'll define the term, give you a detailed application, like how it plays out on the job, and then offer a critical thinking tip. A way to really approach that term when you see it staring back at you in a multiple choice question.
Good plan.
If you really want to understand the whole framework of long-term care, well, this is where we build the foundation, the walls, everything.
Couldn't agree more. Ready to dive into that professional structure and the big federal laws that really govern every single minute you spend giving care.
Let's do it. Where do we start?
Let's start right at the beginning. Your job description itself.
Okay, the basics first. The nursing assistant's role. Now, most people think, yeah, I know this, but the test. It often zooms in on the why the NA is so valuable, maybe beyond just the tests themselves. So what's that core definition we absolutely need to remember?
Well, at its most basic level, your main job, your primary responsibility, is helping residents with their ADLs. Activities of daily living.
ADLs, right?
That means all those daily tasks, the things essential for personal care. Eating, bathing, getting dressed, grooming, using the toilet, moving around.
The fundamentals.
Exactly.
Yeah.
But here's where the test application gets crucial. The NA. You're the constant presence. You're literally the eyes and ears of the healthcare team.
That phrase, eyes and ears, it keeps coming up. It's so critical. Can you give us a really solid example of what that looks like? Because it's not just about spotting dramatic emergencies, is it?
No, precisely. And the test loves to throw questions at you about subtle changes, things that aren't, flashing red lights.
Okay.
So for example, let's say you're helping a resident with bathing. That's an ADL.
Yeah.
And you notice, there's a new rash under a fold of skin. Or maybe you notice their appetite has just been consistently off for, say, 3 days straight.
Little things.
The little things. Or maybe their mood. Usually they're pretty cheerful, but suddenly they're withdrawn, maybe a bit tearful. Your primary job here, it's not to figure out why. It's not to diagnose it.
Not diagnosing?
And definitely not to treat it. It's simply to observe it, document it accurately, and this is key, immediately report that change to the nurse, that reporting duty. Arguably the most vital part of the NA role.
Okay, so quick quiz then. What's the primary way an NA communicates those changes in a resident's status?
It's always going to be reporting directly to the nurse. And then following that up with accurate charting in the resident's record.
Got it. Reporting first. And that duty, that responsibility to report, it leads us straight into the next concept. Structure, the chain of command. Why can't I just, grab the first person I see or maybe call the CEO if I see something really, really bad?
Yeah, it seems logical sometimes, doesn't it? But the chain of command, it defines the legal and the operational structure, the hierarchy you report to. And it's there to make sure there's proper oversight and accountability.
Okay.
So as an NA, you report directly to the charge nurse. It's usually the RN or maybe an LPN, VN who's leading your team for that shift. They're the ones responsible for assigning your tasks.
Okay, but wait a second. Let's say I see something really serious, like maybe a coworker being abusive, and my charge nurse. Maybe they're just swamped, or worse, maybe they're kind of turning a blind eye, or even part of the problem. Why shouldn't I just skip them? Go right to the director of nursing. Wouldn't that be faster? Get the job done?
And that is such a common trap. It's definitely a high miss area on the exam because it feels like the right thing to do in an emergency.
Right.
But while most places do have an open door policy, the chain of command is there specifically to prevent professional liability issues for everyone involved, including you.
Okay, liability.
Yeah. If you regularly skip your immediate supervisor, you disrupt the flow of communication. You miss the proper channels for documenting what happened. And honestly, it can create organizational chaos.
Hmm.
So the rule is, unless the nurse is the person committing the abuse or they are actively ignoring a critical report you've already given them, you must go through them first.
Okay. First step.
First step. Then, if they fail to act appropriately, then you escalate. You go to the next person up the line, the nursing supervisor, the unit manager, whoever is next in your facility structure.
That makes sense. It's about following procedure, accountability.
Hmm.
Okay. Now let's talk about the specific instructions we get from the charge nurse. That's called delegation, right?
Exactly. Delegation is when a licensed professional, the nurse, transfers responsibility for a specific task to you. But here's the crucial part. The nurse delegates the task, but they keep the overall accountability for that resident's care.
Ah, okay. They're still responsible overall.
Yes. And the task they delegate must always be something within your scope of training, something you were taught and proven competent in. Like a nurse might delegate taking vital signs, or measuring and recording fluid intake and output INO, or maybe performing a basic non-sterile wound dressing change, things like that.
Okay. That leads us perfectly into maybe the single most important concept for protecting your job, your certification, your scope of practice. What are those absolute red lines? The things NAs must never do, even if a busy nurse asks you to.
Right. This is the crucial test tip territory. And it's all about tasks that need a higher level of training or involve actual medical judgment. NAs must never perform procedures outside their scope.
Never.
Never. This includes anything that requires sterile technique. So you can't do complex sterile dressing changes. You absolutely cannot give medications, oral, IV, injections, none of it.
No meds.
No meds. You can't administer tube feedings. You can't perform invasive procedures like inserting urinary catheters or NG tubes. And maybe most importantly, you must never make a diagnosis or give medical advice. You just observe and report.
Okay, let's play out a scenario. This tests that boundary. You like your charge nurse, they're great, but they are completely slammed, totally overwhelmed. They turn to you and say, hey, can you quickly just pour Mrs. Smith's routine oral diabetes medicine? It's right there in the cup, ready to go. What do you do? How do you respond? And why?
Okay, this happens, and you have to be ready. You must politely but firmly refuse. You state clearly, I'm sorry, but that is outside my scope of practice as a nursing assistant.
Directly stated.
Directly stated. And then you need to immediately report that request up the chain of command, because asking an NA to give medication is an attempt at illegal delegation. It puts the resident at risk, and it puts you at risk.
How does it put me at risk?
Because it protects you. If you actually did give that medicine and Mrs. Smith had an adverse reaction, you would be legally liable. You performed a task you're not licensed or trained to do, and you risk losing your competency evaluation result, that certification you're studying so hard for right now, the one listed on the state registry. You have to protect your certification above everything else. Don't let anyone pressure you into crossing that line.
Okay, protect the certification. Got it. So we've got the structure down. Now let's talk about the legal bedrock, the big laws. Let's start with OBRA, the Omnibus Budget Reconciliation Act. Sounds kind of boring and bureaucratic. But why is it actually foundational for us?
Yeah, the name isn't exciting, but OBRA passed back in 1987. It literally revolutionized long-term care in the U.S.
Yeah.
It shifted the whole standard of care from just custodial, like providing basic shelter and food.
It's just warehousing people.
Kind of, yeah. It moved it to a standard that is rights-based. For the test, you absolutely have to remember its key mandates. Yeah. Setting the minimum training hours at 75, requiring 12 hours of annual in-service education to keep your skills up. And it established the State Registry of Nursing Assistants. But the real relevance, the philosophical shift, is that OBRA mandated the creation and enforcement of resident rights. It guaranteed a certain standard of services that must be provided in every long-term care facility. It's the reason residents have actual control over their lives and their care.
So OBRA gives the rights and sets the care standards. Then IPA comes in and provides the absolute legal shield for privacy. What exactly are we protecting under IPA, the Health Insurance Portability and Accountability Act?
We are protecting PHI. That stands for Protected Health Information. And this is any piece of information that can identify a resident and is linked to their health status, their care, or payment for their care.
Any piece? Like what specifically?
It's broad. Their name, obviously, room number, diagnosis, any medical history, photos, insurance information, even just the fact that they're a resident in that facility. All of that is PHI.
Okay, let's hit a scenario that might seem a bit gray. You walk into the break room, Two coworkers are there talking kind of loudly about Mr. Jones in room 310. They're saying, oh, he has this terrible infection and we're really struggling to control the odor. Is that a HIPAA violation? I mean, they're coworkers, they're not talking to the public?
Yes, absolutely. That is a reportable breach of HIPAA.
Even in the break room?
Yes. Discussing any resident's confidential information in a public or even semi-public space like a hallway where visitors might pass, the cafeteria, or yes, even the break room where non-care staff like housekeeping or dietary might overhear, that's considered unauthorized sharing of PHI. HIPAA requires what they call reasonable safeguards to protect privacy. Whispering in the break room isn't enough. Take it to a private area like the nurse's station report room.
Got it. Okay, now for the really, really critical high-miss area for HIPAA that involves pretty much every single new graduate today, social media. Give us the absolute non-negotiable rule here.
This one, it's a career ender. Plain and simple. Posting anything about residents online is forbidden.
Yeah.
Anything.
Yeah.
A picture of their room, even if they're not in it. A description of a funny thing that happened. A vague post complaining about how difficult a resident was, even if you don't use their name. If the details are specific enough that someone could potentially figure out who you're talking about.
Like my resident in 3B with the broken hip?
Exactly. That's a violation. Posting details from their care plan, complaining about work stuff that mentions resident conditions, putting on Facebook, TikTok, Instagram, Snapchat, even in a private text message to a friend who doesn't work there. It's all an illegal breach of confidentiality.
Illegal, not just against policy.
Illegal. And the consequences are swift and severe. Immediate termination from your job, revocation of your nursing assistant certification by the state registry, and potentially legal charges and fines. The rule is dead simple. If it involves a resident, their condition, their care, or anything that happened at this facility related to them, do not post it, period. Treat anything electronic texts, posts, even emails with the same seriousness as a lock paper medical chart. Okay, so we've covered the big federal laws. Now let's zoom in a bit, focus on the day-to-day expectations for your behavior on the job. This part is about distinguishing between just, general professional standards and those really serious legal pitfalls that can land you in huge trouble, like criminal charges or losing that certification we just talked about.
Right. Let's start by defining the difference between conduct and ethics. They sound kind of similar, but they're distinct in a professional setting, aren't they?
They are. Conduct is really about your behavior, how you act while you're at work. It means things like following the facility's policies and procedures, being punctual, dressing appropriately, maintaining a professional demeanor with residents and colleagues.
How you act.
How you act. Ethics, on the other hand, are more internal. They're the rules of right and wrong, the moral principles that guide your actions. Things like honesty, fairness, respect, integrity.
Okay, so ethics guides the conduct.
Precisely. Your ethical compass should direct your professional conduct.
All right, here's that classic test scenario for ethics. We kind of touched on it before. You're providing morning care. You see a $20 bill just sitting on the resident's nightstand. The resident has dementia and is currently asleep. What do your ethics tell you to do?
Ethics demand honesty and protection of the resident's property. So you must immediately report finding the money to the nurse. You don't just leave it there hoping they'll find it later. You don't assume they don't need it or decide, oh, I'll just hold on to it for safekeeping for them.
Why not? Why is reporting it the only ethical choice?
Because that ethical failure, deciding to just ignore it, or worse, pocket it, it leads directly to a serious legal violation called stealing, which is simply taking anything that doesn't belong to you.
Doesn't matter if it's cash, a resident's necklace, or even facility supplies like extra gloves or linens for home.
Exactly. It's all stealing.
Yeah.
By reporting the $20 immediately, you prevent even the appearance of theft. And that's absolutely crucial for maintaining trust with the resident, their family, and your employer.
Makes sense. Okay, another core expectation, dependability. This isn't just about physically showing up for your shift, is it? There's more to it.
Oh, much more. Dependability means being reliable in every sense. Yes, it means being on time for your shift, ready to work, but it also means you complete your assigned tasks thoroughly and correctly. You follow through. And critically, if you are sick or have an emergency and can't come in, you notify your employer promptly, following the facility's specific call-out procedure. You don't just no-show. Dependability also includes your professional presentation being clean, wearing a clean uniform, being well-groomed. It reflects a standard of competence and respect for the people you're caring for.
Right. It's the whole package of being reliable. Now let's talk about one of the highest stakes integrity violations that comes up on the exam, fraud. We mentioned falsifying charting earlier, but let's dig into why this is considered such a severe violation.
Okay, so fraud is defined as intentional dishonesty or deception, usually for some kind of gain. In healthcare, it very often revolves around money and billing. The most common type of fraud committed by NAs is falsifying records.
Like charting that bath that never happened?
Exactly. Charting a bath. Charting that you turned the resident every 2 hours. Charting that you assisted them with a meal when you didn't actually do it. Why is this so incredibly severe? Because facilities get paid, they get reimbursed by government programs like Medicare and Medicaid based on the documented proof of the care they provided.
Ah, the documentation trail.
Right. If you chart care that wasn't delivered, you're essentially helping the facility, even if unintentionally, steal taxpayer money through deception. It's not just breaking a facility rule. It's potentially a criminal act with serious legal consequences.
Wow. Okay. Let's shift to how words themselves can be used unprofessionally or harmfully. Specifically, slander. What is that exactly?
Slander is when you spread false information verbally, spoken words that harm someone else's reputation.
False information. Spoken.
Correct. So if you're gossiping with coworkers and saying, oh, that nurse on the night shift, she's totally incompetent, she sleeps on the job, and that's not true. That's slander. Or if you claim a resident is faking your pain or lying about their symptoms and it's false. That's slander against the resident.
Okay, here's a distinction, though. What if I post mean but maybe true comments about a coworker on my private Facebook page after work? Is that slander? Is it illegal?
Well, legally, truth is generally a defense against slander or libel, which is written defamation. So if what you posted was actually true, it might not meet the legal definition of slander libel. However, and this is a big however for your job, even if it's legal to post nasty things about coworkers online, it is absolutely unprofessional. It violates workplace conduct policies, destroys teamwork, and creates a hostile environment. The facility can, and very likely will, reprimand or even fire you for that kind of behavior, regardless of whether it meets the strict legal test for slander. Professionalism extends beyond just illegal acts.
Good point. Okay, now we absolutely have to clearly define the difference between two really critical legal violations concerning resident safety. Assault and battery. So many students get these two confused.
Yes, they do. And they are tested frequently because they define that crucial boundary between intimidation or threats and actual physical harm. Let's break it down. Assault is the act of threatening to harm someone physically in a way that puts them in immediate fear of being harmed.
Threatening. Fear.
Exactly.
Yeah.
And crucially, you do not have to actually touch the person for it to be assault. The threat itself is the violation. If you shake your fist at a resident and yell, if you pull that call light cord one more time, I swear I will tie you down. Even if you don't touch them, that is assault. You've created fear of imminent harm.
Okay. Threat, assault. So what's battery then?
Battery is the actual physical act. It's intentionally touching someone in a harmful or offensive way without their consent.
Touching without consent.
Right. This is a huge concept for NAs because of resident rights. If you force a resident to take a shower when they have clearly and verbally refused, that is battery. Even if you genuinely believe the shower is medically necessary for their hygiene, forcing care on a competent resident who refuses is battery.
Even if it's for their own good.
Even if you think it's for their own good. Their right to refuse prevails. Obviously, physical violence, like hitting or pushing a resident, that's clearly battery as well.
So back to that medication example. If a resident refuses their pill and I know they need it, maybe I hold their arms down and physically force the pill into their mouth. That's battery.
100% correct. That is a complete violation of their right to refuse, and it crosses the legal line squarely into battery. Major violation.
Okay. Speaking of physically holding people down, we also need to cover false imprisonment and involuntary seclusion. What are those?
False imprisonment is unlawfully restraining a person or restricting their freedom of movement. This isn't just about tying someone up, although using physical restraints like vests or wrist ties without a current, valid doctor's order is definitely false imprisonment.
What else counts?
It also includes using chemical restraints, giving medication solely to sedate or subdue a resident, not for a legitimate medical reason. And it can even include misusing environmental factors, like keeping all 4 side rails up on a resident's bed when it's not medically necessary, effectively preventing them from getting out of bed.
Ah, side rails too, okay. And involuntary seclusion.
That's specifically about separating a resident from other people or confining them to a specific area against their will or the will of their legal representative, like locking a resident in their room because they're being disruptive or forcing them to stay in a quiet area when they want to leave. NAs must always prioritize and protect the residents' freedom of movement and their right to associate with others.
Got it. And finally, in this section, a really huge issue in workplace safety and also in resident interactions, sexual harassment.
Yes. Sexual harassment is defined as any unwelcome sexual advances, requests for sexual favors, or other verbal or physical conduct of a sexual nature in the workplace.
Unwelcome is key.
Absolutely. This includes things like making inappropriate sexual jokes or comments, staring or leering, unwanted touching, or repeatedly asking someone out after they've said no. It can happen between coworkers, between a supervisor and subordinate, or even involve residents harassing staff or staff harassing residents.
So goes always.
It does. As a professional, you have to maintain strict professional boundaries. This also ties into facility policies about things like accepting large gifts or money from residents. While a small token might be okay depending on policy, accepting significant gifts can blur that line between professional care and a personal relationship, which raises serious ethical red flags and can sometimes be a precursor to boundary violations or exploitation. Best practice is usually to politely decline anything beyond a very small token and report the offer to your nurse. All right, moving into what might be the most serious legal mandates in all of long-term care. We're talking about protecting residents from harm. As an NA, you are a mandated reporter. That means you are legally required to report suspected abuse or neglect. Knowing these definitions and recognizing the signs is absolutely non-negotiable for the exam and, more importantly, for your job.
Mandated reporter. That's a heavy responsibility. Let's start with the big umbrella term, abuse. What does that encompass?
Abuse is broadly defined as any action, intentional or reckless, that causes harm, or is likely to cause harm, to a resident. This can be physical harm, emotional or psychological harm, sexual harm, or even financial exploitation. Abuse is generally seen as an active infliction of injury or distress.
An action taken. Okay. The test often presents scenarios involving non-physical abuse, like verbal abuse. Can you give a clear example of that?
Sure. Verbal abuse includes using harsh or threatening language, yelling or screaming at a resident, calling them names, humiliating them, or using sarcasm that demeans or degrades them. For instance, imagine a coworker who's clearly frustrated with a resident who keeps calling out. If that coworker yells, "Oh, just shut up, you old fool, can't you see I'm busy?" That is absolutely verbal abuse.
And what's my obligation if I witness that?
Your legal obligation is crystal clear. You must immediately report what you saw and heard up the chain of command to your charge nurse or supervisor. It doesn't matter if you like the coworker or if they were just having a bad day. Reporting suspected abuse is the law. It is not optional. Failure to report can have serious consequences for you, too.
Okay. The law, not optional. Now, we really need to get specific about the signs of abuse because test questions love to describe potential signs and ask you if they warrant reporting. They often focus on recognizing specific, suspicious injuries that might indicate non-accidental harm.
Right. You need to train your eyes and ears. Pay close attention to patterns of injury. Things that raise red flags include bilateral injuries like bruises on both upper arms, suggesting someone was grabbed forcefully.
Both sides. Okay.
Injuries in unusual shapes, maybe resembling teeth marks, or linear marks like from a belt buckle or strap. Burns, especially small circular ones like cigarette burns, are highly suspicious. Unexplained fractures, dislocations, sprains, especially if the resident's explanation doesn't quite fit the injury. Those are critical red flags.
So physical signs are key.
They are. But remember, abuse is often emotional or psychological too, and the signs can be behavioral. Report things like sudden, unexplained changes in behavior, extreme fearfulness, maybe cowering when someone approaches, unusual apprehension or anxiety, withdrawal from social interaction, loss of appetite, or sudden poor self-control or aggression, especially if these behaviors are new or drastically different for that resident. You need to know your resident's baseline to spot these changes.
Know the baseline, report the change. Okay. Now, on the other side of the coin, we have harm that's caused not by doing something wrong, but by failing to do something right. Harm by omission. This is neglect.
Exactly. Neglect is the failure to provide necessary care or services to a resident when that failure results in, or could result in, physical harm, pain, mental anguish, or emotional distress. It's the absence of required action.
Can you give some common examples?
Sure. Consistently ignoring call lights, leading to falls or unmet needs. Not assisting a resident with eating or drinking when they need help, leading to malnutrition or dehydration. Failing to provide basic hygiene, like not changing a resident's soiled incontinence brief for hours and hours, leading to skin breakdown, not performing scheduled turning and repositioning for someone at risk.
Failing to provide care. So what are the key signs of neglect that an NA absolutely must report right away? What should we look for?
But look for the physical evidence of that missed care. Obvious signs include symptoms of dehydration like dry mouth, sunken eyes, skin that tense when pinched, or maybe just no fresh water readily available at the bedside.
Dehydration.
A significant unexplained weight loss or a consistently poor appetite can signal neglect if feeding assistance isn't being provided. Poor hygiene is a big one. Things like body odor, unkempt hair, dirty fingernails, or signs of body lice or scabies. And probably the most classic sign often linked to neglect is the presence of pressure injuries, also known as bed sores or decubitus ulcers.
Pressure injuries. Why are they such a strong indicator?
Because they often develop due to a failure to consistently turn and reposition the resident as required by their care plan, especially if they are immobile. It shows that basic preventative care likely wasn't being done. Also, if a resident tells you, "I haven't gotten my pain medicine today," or any prescribed medication, you must report that to the nurse immediately as potential neglect or a medication error.
Got it. Report, report, report. These reporting mandates, they're directly tied to the protections that were formalized back with OBRA in the Residents' Bill of Rights. Let's quickly review the foundational guarantees in that Bill of Rights.
Absolutely. The Residents' Bill of Rights, which is federal law thanks to OBRA, guarantees several fundamental things for people living in nursing homes. Key ones include the right to quality of life, which means care must enhance, not diminish their life. The right to the maintenance of their physical, mental, and psychosocial wellness to the highest possible level. The right to be fully informed about their own health condition and treatments in a language they understand. And critically, the right to participate in their own care planning, including the right to provide informed consent for treatments, or the right to refuse treatment.
That right to refuse is huge. Let's focus on another key right, the right to make independent choices. Give us the scenario that illustrates this.
Okay. Imagine a resident, Mrs. Davis, absolutely insists on wearing her favorite shirt today, but it's noticeably wrinkled, maybe has a small stain on the cuff. Your job as an NA upholding her rights is to promote her dignity and her choice.
So what would be a violation?
A violation would be saying, "Oh no, Mrs. Davis, you can't wear that dirty thing," and forcing her into a different, perfect and clean shirt that you picked out, but that she doesn't want to wear.
And promoting her right.
Promoting her right means respecting her decision. You allow her to wear the shirt she chose. Maybe you gently offer, "Would you like me to try and iron this quickly, or perhaps we can wash it later today?" But ultimately, you respect her current choice. Even seemingly small decisions, what time they want to get up, what activity they want to attend, what they choose from the menu, these are all crucial for maintaining an adult's sense of control and autonomy, and they are legally protected rights.
Okay. What right would I be violating if, say, during morning rounds, I just walk into a resident's room, go over to their dresser, and start rearranging their personal photos and little keepsakes without even asking them first?
That's a direct violation of their right to privacy and confidentiality regarding their own person, their personal space, and their possessions. Their room is their home within the facility. You must always knock, announce yourself, and respect their personal space and belongings just as you would in anyone's private home.
Knock first. Respect the space. Got it. And finally, if a resident does have a complaint, maybe it's about the food quality, maybe they feel a staff member was rude, maybe they believe one of their rights was violated, who is that independent person outside the facility staff that they can turn to for help?
That person is the ombudsman. Long-term care ombudsman. Every state has an ombudsman program mandated by federal law.
Ombudsman, what do they do?
The ombudsman is a specially trained advocate for residents. They are completely independent of the nursing facility. Their job is to investigate residents' complaints and help resolve problems related to care, rights, or quality of life.
So they work for the resident?
Essentially, yes. They advocate solely on behalf of the resident. They educate residents and staff about rights, they mediate disputes, and if necessary, they can even represent the resident's interests in legal or administrative proceedings. Residents have the absolute right to contact the ombudsman at any time, privately and without fear of retaliation from the facility. Their contact information must be posted visibly in the facility.
Okay, let's shift gears slightly. We've laid down the legal and ethical rules. Now we need to talk about the philosophy that really ties all of that together. Person-centered care. This is the whole approach of treating the resident not just as a diagnosis or a set of tasks, but as a unique individual. It means looking at and addressing their physical, mental, social, and even spiritual well-being. The whole person.
Right, treating the whole person. And a core concept here is promoting resident independence. We touched on this earlier with ADLs, but why is it so important for an NA to prioritize a resident's independence, even if it makes our job slower or harder? Because independence isn't just about physical ability. It's fundamentally linked to the resident's existing skills and, maybe even more importantly, their self-esteem and sense of worth. The goal of good care is always to maximize what the resident can do for themselves, not just focus on what they can't do.
Maximize ability.
Yes. Think about that scenario where a resident, maybe they have arthritis or weakness from a stroke, is very slow at, say, buttoning their shirt or brushing their own teeth. It would take you, the NA, maybe 5 seconds to just do it for them.
Much faster.
Much faster for you. But if they are physically capable of doing it, even if it takes them 5 or 10 minutes, you must encourage and allow them to do it themselves, providing only the help they truly need. If you constantly step in and take over, they lose that skill, they become more dependent, and it chips away at their confidence and their overall quality of life.
Okay, so quality of life. What does that really mean in this context? It's more than just being medically stable.
Right. Oh, absolutely. Quality of life is about their overall comfort, their emotional happiness, feeling safe, having meaningful social connections, and feeling like they still have purpose and value. It's not just about blood pressure numbers or whether their labs are okay. It includes things like their personal preferences being respected, having opportunities for enjoyment and engagement. And this ties directly into the resident's environment.
Their living space.
Yes. Their room, the common areas. It needs to be safe, of course, but also clean, comfortable, and, ideally, personalized to feel like they're home, not just a hospital room.
We talked about safety before, especially fall risks. What's a simple environmental safety check related to clutter that an NA should always be doing?
Falls are a huge risk. So a key check is looking for hazards in their immediate environment. Is the pathway from the bed to the bathroom clear? Are there electrical cords stretched across the floor? Are there throw rugs that could slip? Is the room overly cluttered with furniture or personal items piled up?
Finding that balance.
Exactly. You have to balance respecting their desire to have their personal things around them with the critical need for fall prevention. It often means working collaboratively with the resident. Ms. Jones, could we maybe organize these boxes slightly differently to make sure you have a clear path to walk? Keep those pathways clear.
Good tip. Okay, let's talk more about that philosophy of holistic care, caring for the whole person. We often prioritize needs using Maslow's hierarchy. What are those foundational basic needs or physical needs that Maslow says we absolutely must meet first?
Right. Maslow put the most fundamental needs for survival at the bottom of his pyramid, meaning they have the highest priority. These are things like oxygen, food, water, adequate rest and sleep, shelter, safety, elimination, using the toilet, and activity or movement. These physiological needs have to be met before someone can really focus on higher level needs.
And the test loves to make you choose between needs, doesn't it?
Oh, absolutely. They'll give you a scenario with a resident expressing multiple needs simultaneously, and you have to pick the priority action.
Okay, give us a tough one. Pit 2 different levels of need against each other.
All right. Let's say a resident is tearfully telling you how profoundly lonely they feel since their spouse passed away. That's a clear social need, maybe an emotional need too. At the exact same time, you notice they seem quite short of breath and look anxious, maybe clutching their chest slightly. That signals a potential physical need or safety need related to breathing or circulation.
Okay, loneliness versus shortness of breath. Which one do you address first?
You must always prioritize the physical need. Shortness of breath, chest pain, signs of acute physical distress. These take immediate precedence over social or emotional concerns, no matter how valid those concerns are. Because the physical need is essential for immediate survival. You address the breathing issue first, get the nurse involved immediately, and then, once they're physically stable, you can address the loneliness.
Physical first. Always. Okay, so once those basic physical and safety needs are met, we move up Maslow's pyramid to things like emotional needs, social needs, and even spiritual needs. How does an NA support these higher level needs as part of holistic care?
This is where truly caring for the whole person comes in. Emotional needs, the need for belonging, love, affection, feeling secure. You meet these partly by just Being present, listening actively and empathetically when a resident talks about their feelings, validating their emotions, sounds like you're feeling really sad today, and providing comfort and reassurance.
Just listening helps.
It helps immensely. For social needs, the need for friendship, connection, interaction, you can facilitate this. Encourage residents to participate in facility activities, help them make phone calls to family or friends, maybe introduce them to other residents with similar interests. You can also support things like intergenerational care programs where residents get to interact with children or young adults, which can be very beneficial.
Connecting people and spiritual needs.
Spiritual needs refer to a person's connection to their faith, their values, their sense of meaning and purpose in life. It doesn't always mean organized religion. If a resident expresses sadness related to spiritual distress or a desire to connect with their faith, you support that. You might offer to contact clergy, like a priest, rabbi, minister for them, help them find religious services broadcast on TV or radio, or assist them in reading religious texts if they wish. It's about respecting and facilitating whatever gives them spiritual comfort.
Okay, holistic care covers a lot. Now, finally, let's quickly identify some other key members of the healthcare team beyond just the NA and the nurse. The exam might ask you to know who does what.
Right. Knowing the roles of different specialists is important. You'll work alongside many professionals. Key ones to know for the test include the physical therapist, PT. Their focus is on improving movement, strength, balance, and mobility, often after an injury or surgery. They develop exercise plans and teach residents how to use assistive devices like walkers or canes. You often help residents practice the exercises the PT prescribes.
TT for movement.
The dietitian, RD registered dietitian, they are the nutrition experts. They assess residents' nutritional status, plan menus, and design special therapeutic diets, like low-sodium diets for heart conditions or thickened liquids for swallowing problems. A crucial test tip here. NAs are vital in reporting information to the dietitian or nurse, things like how much the resident ate intake, if they have a poor appetite, or if they're having trouble swallowing.
Report intake to the RD nurse.
Okay. The social worker, MSW, Master of Social Work. They help residents and families cope with the emotional and social challenges of illness, disability, or living in a facility. They handle things like admission paperwork, counseling for adjustment issues, resolving family conflicts, connecting people to financial aid or community resources, and very importantly, coordinating discharge planning when a resident is ready to leave.
Social worker for coping and discharge.
The psychiatrist. This is a medical doctor, MD, who specializes in diagnosing and treating mental health disorders. They can provide therapy and prescribe medications for conditions like depression, anxiety, or psychosis. And the podiatrist. This is a doctor who specializes in treating problems of the feet. Foot care is incredibly important, especially for residents with diabetes, as they are prone to serious foot complications that can lead to infections or even amputations if not managed carefully. ANAs often assist with basic foot care but report any abnormalities to the nurse podiatrist.
Got it. Different specialists, different roles. Now, we need to make sure we don't mix up the two main branches related to studying aging. Can you clearly differentiate between geriatrics and gerontology?
Sure. It's a common point of confusion. Geriatrics is the specific branch of medicine that focuses on the health care of elderly people. It deals with the diseases and health problems common in older adults and their treatment. Think geriatric medicine.
Medicine for older adults.
Right. Gerontology, on the other hand, is much broader. It's the scientific study of the aging process itself, the biological, psychological, and social changes that occur as people get older. It studies how we age, not just the diseases of aging.
Study of aging versus medical care for aging.
Exactly. And this distinction leads right into a major testing area, confusing normal changes of aging with actual signs of illness or decline that need reporting. What are some normal aging changes that tests might try to trick you with? Okay, so some things are expected as people get older. Things like some decrease in muscle strength, maybe reflexes get a bit slower, reaction times lengthen. There might be some loss of height due to changes in the spine. Bones might become weaker and more brittle. Osteoporosis risk increases. Skin becomes thinner and less elastic. These are generally considered normal parts of the aging process.
Okay, those are normal. What's not normal then?
What's not normal, and what you must report immediately, are things like sudden onset of confusion or delirium, acute new incontinence, loss of bladder or bowel control when they were previously continent, significant debilitating memory loss that interferes with daily function that's not normal aging, that could be dementia or another medical issue, sudden changes in mobility or balance, severe pain or signs of depression like persistent sadness or loss of interest. The test loves to trip you up here. Minor forgetfulness, like where you put your keys, may be normal. Forgetting how to use the phone or recognize family members, not normal. That resident might be described as cognitively impaired, and it needs investigation.
Report anything sudden or significantly different.
Got it. And finally, let's touch on the impact this demanding job can have on us, the caregivers. Burnout and stress. Yes, really important for self-care and longevity in the field. Stress is the body's natural physical, mental, and emotional response to any demand or challenge. Some stress can be motivating, but chronic high levels are harmful. Burnout is what happens when that stress becomes overwhelming and prolonged. It's a state of emotional, physical, and mental exhaustion.
Exhaustion. What does burnout look like?
It can manifest as chronic fatigue, feeling cynical or detached from your work and the residents, maybe increased irritability or anger, feeling ineffective, or even physical symptoms like headaches or stomach problems. It can lead to frequent absences or wanting to quit. A professional NA needs to recognize the signs of burnout in themselves and their colleagues.
And what do you do?
You need to practice self-care, getting enough rest, eating well, exercising, having interests outside of work. Utilize facility resources if available, like employee assistance programs, and importantly, report to your supervisor if you feel that stress or burnout is interfering with your ability to safely and effectively perform your duties. Taking breaks, seeking support, and participating in continuing education can help prevent burnout and maintain your professional competence and compassion. #outro. So we've really covered the waterfront today, laying down the entire legal and ethical foundation you need for your certification exam. If you're going to really focus your final review on just 3 high-stakes areas from this deep dive, I'd say make absolutely sure they are. First, understanding the full legal scope of HIPAA breaches, especially everything involving social media and verbal indiscretions.
IPA, number 1.
Second, your mandatory reporting obligations for abuse and neglect. Know those definitions cold and be hypervigilant for all the signs we discussed, physical and behavioral.
Abuse and neglect reporting. Got it.
And third, maintaining those strict boundaries within your scope of practice. Never cross that line, and really understand the critical difference between assault, the threat, and battery, the touch.
Yeah.
These concepts. They really underpin almost every resident care scenario you are likely to encounter on the Headmaster Test.
That's absolutely the essential knowledge. Okay, before we wrap up part 1, let's leave you, our listener, with one final provocative thought. Something to mull over that really ties together OBRA, resident rights, and the care planning process we mentioned.
Okay, I'm curious.
If we know, and we do know that you, as an NA, are legally required to follow the resident's care plan to the letter, and we know that the care plan is legally supposed to be designed around the resident's independent choices and preferences, because that's their right under OBRA, then how often do you think that care plan actually needs to be formally reviewed and updated to make sure it truly reflects what a resident currently needs and desires, especially since people's conditions and preferences change over time?
That's a great question, connecting the dots. The frequency of review is actually mandated. It's tied to the minimum data set, or MDS assessment process. Federal regulations require a comprehensive MDS assessment shortly after admission, and then major reviews must happen at least quarterly, every 3 months, and at least annually. Plus, a significant change assessment needs to be done whenever there is a major change in the resident's physical or mental condition.
Quarterly, annually, and with any major change. That constant need for review really underscores that care isn't static, is it? It has to be this dynamic, ongoing, truly person-centered process.
Couldn't have said it better myself.
Thank you so much for diving deep with us today. Stick with us for the next 9 parts of this series as we continue to break down every essential chapter to help you ace your Headmaster exam.
Welcome to part 2 of our Key Terms podcast series for Headmaster Test Prep. There are 10 parts total, 1 for each chapter. Stick with us to ace your exam.
Okay, part 2 and chapter 2, Foundations of Resident Care and Safety, this is. Well, it's huge. It's really the foundation, like the title says.
It really is. If chapter 1 was just getting your bearings, this chapter is the absolute bedrock. We're talking communication, safety, infection control, handling emergencies, pretty much everything you do day to day.
Exactly. And our mission here, just to remind everyone, is laser focused on you, the nursing assistant grad who's getting ready for that state written test.
Right. We're not just reading definitions. We're trying to cut through the noise, give you the essential terms, sure, but also the why. Why does this show up on the test? What kind of scenario will they throw at you?
We want you to see how these terms play out in real clinical situations. What does it actually look like on the floor? Because that's what the test questions are often based on.
So we've got this structured into, 6 main sections? We'll start with communication, then move through professionalism, infection control, safety and movement, non-medical emergencies, medical emergencies, and wrap up with end-of-life care.
Sounds like a plan. Let's jump right into Section 1, the language of care, communication and reporting, terms 1 through 9.
Okay, the absolute basics. First term, communication. Seems simple, right? Just talking.
Well, yes and no. In healthcare, communication is much broader. It's sharing information, yeah, but it has to be clear, accurate. It can be verbal, written, even electronic sometimes.
And it's not just talking to the resident. It's communicating with the family, the nurses, the whole team.
Precisely. But then there's the other side of the coin, nonverbal communication. This is huge.
Yeah. This is everything but the words. Your posture, facial expressions.
Your body language, your gestures, are you making eye contact? Are your arms crossed? Are you leaning in or pulling away? All of that sends a powerful message.
And the test loves this. Why? Because NAs have to be masters of observation. You need to be able to read those nonverbal cues.
Especially when there's a conflict. That's the key takeaway here for the test. What happens when what the resident says doesn't match what their body is telling you?
Good example. Like you ask Mr. Jones, are you in pain? And he says, nope, I'm fine.
Do you white-knuckling the side rails? He's grimacing, maybe sweating a little. That's a major conflict.
Absolutely. And which one do you pay more attention to?
Usually the nonverbal. That unspoken message is often the truth peeking through. Pain, fear, anxiety, things they might not want to admit or can't quite put into words.
So your job is to see that conflict, note the body language, the grimacing, the tight grip, and report that objective observation.
Exactly. And quick tip here. Observation itself is a form of nonverbal communication from you. When you really pay attention, when you notice those little details, you're communicating care and concern without saying a word.
That's a great point. Okay, so we observe carefully, we notice these things. Now we need to report them accurately. This brings us straight to objective data versus subjective data.
Critical distinction. Getting this wrong messes up your documentation and can impact care.
Let's break it down. Objective data. Think object. It's something real, tangible, something you can observe directly using your senses or a measuring tool. Facts.
Things you can see, like a rash, swelling, pale skin, the color of urine. Things you can smell, like a fruity breath odor or a foul womb smell.
Things you can hear wheezing, coughing, moaning. Or things you can touch or measure: hot skin, a pulse rate, a blood pressure reading, a temperature of 101.
Right. Independent facts. Now, subjective data. Think subject. It comes from the person, the subject. It's what the resident tells you about how they feel.
Their symptoms, their perceptions. I feel dizzy, my stomach hurts, I'm scared.
Things you can't directly see or measure yourself, you have to rely on the resident's report.
And the test will try to trip you up by mixing them in a scenario. Like you find a resident breathing rapidly and their skin feels cool and clammy. That's objective.
You saw the breathing, you felt the skin. Objective.
Then the resident gasps, I feel like I can't catch my breath. That statement.
That's subjective. You report both, of course, but you need to know which is which for your documentation. The objective signs often back up the subjective complaint.
Speaking of documentation, that's our next term, along with medical record and military time. Documentation is just writing it all down, right?
Writing down your observations and the care you provided. It needs to be accurate, factual, descriptive, and timely, and it becomes part of the resident's official medical record, the legal document tracking their care.
And the golden rule.
If you didn't chart it, it didn't happen, legally speaking.
Which is why accuracy is paramount. And part of that accuracy, in most facilities, involves using military time.
The 24-hour clock. It just eliminates any confusion between AM and PM. You give care at 2.0 in the afternoon.
You don't write 2.0, you write 1400.
Exactly. 7.0 PM is 1900. Midnight is 2400 or 000. It ensures everyone reading the chart knows precisely when something occurred. The test expects you to know how to convert this.
Okay, that makes sense. Precision is key. So we've covered communicating, observing, reporting, documenting. Now let's shift gears into how we act professionally. Section 2, professionalism and interpersonal skills.
Right. Terms 10 through 18, starting with your core duties. The nursing assistant's role, observation, and reporting.
We've touched on observation and reporting, but let's define the nursing assistant's role clearly. What are you there to do?
Your primary role involves providing direct personal care, bathing, dressing, feeding, toileting, assisting with activities of daily living or ADLs, also taking vital signs, ensuring safety, and making beds.
And woven through all of that is observation, constant, careful watching.
Looking for any change. Skin condition, mood, appetite, mobility, level of alertness. Anything different from their baseline, you're the eyes and ears for the nurse.
Which leads directly to reporting. You see something, you say something. But when do you report?
That's the million-dollar question for the test. Some things can wait for your end-of-shift report, but others require immediate reporting.
Like what? What gets you running to the nurse right away?
Anything potentially serious or life-threatening. A fall, obviously. Sudden, severe chest pain. Difficulty breathing or shortness of breath.
Okay. What else?
A high fever, especially if it spikes suddenly. Any sudden weakness or numbness, particularly on one side. Sudden confusion or change in mental status. Bleeding.
Got it. Those are the big obvious ones. But what about less dramatic things?
This is where the test gets tricky. A classic high-miss area example. You're helping turn a resident, and you notice a small, red, warm area on their hip or tailbone that wasn't there before.
Just a little red spot. Seems minor.
It seems minor, but you must report it immediately. That redness could be the very first sign of skin breakdown, the start of a pressure ulcer. Catching it now allows the nurse to intervene before it becomes a serious wound. Delaying the report could be disastrous.
Okay, that makes sense. Report early, report often, especially for those key signs. Now, moving into ethical responsibilities. Confidentiality, phone etiquette, and general etiquette.
Confidentiality. Non-negotiable. HIPAA laws are strict. You must keep all resident information private.
Everything. Like their diagnosis, their family problems, even just who visits them.
Everything. Medical info, financial info, personal life details, even photos. You only discuss resident information with members of the care team who absolutely need that information to do their job.
And never in public areas, right? Like the hallway or elevator?
Absolutely not. Or the cafeteria. The test loves scenarios about breaches. What if you overhear a coworker loudly discussing a resident's incontinence issues in the break room?
You have to report that coworker. It's a breach. You can't just ignore it.
Correct. And that applies to phone etiquette, too. You answer the phone professionally, identify the facility and yourself, but you never give out confidential information about residents or staff over the phone.
Even if they say they're family.
Nope. You can't verify who they are, offer to take a message, or transfer the call to the nurse, who has procedures for verifying identity. Politeness and discretion are key.
Okay, let's shift to managing difficult interactions. Terms like conflict, defense mechanism, and de-escalation.
Conflict is inevitable. Residents are often stressed, scared, in pain, or dealing with huge life changes. This can lead to challenging behaviors.
And sometimes they use defense mechanisms to cope, right? What are those exactly?
They're unconscious ways people protect themselves from stress or difficult feelings, like denial, I'm not sick, I don't need help. Or projection, blaming you for something they did, like misplacing their own dentures. Or repression, kind of blocking out unpleasant thoughts.
So seeing these isn't necessarily bad, it just tells you the resident is struggling.
Exactly. It helps you understand the why behind their behavior, which leads us to the crucial skill of de-escalation. How do you calm someone who is agitated, angry, or even combative?
This sounds really important for safety. What are the steps? The test probably wants specifics.
It does. Step 1. Ensure safety, yours and theirs. Stand back a bit, at least an arm's length. Position yourself so you have an exit near the door, not cornered. Keep your posture open and non-threatening.
Okay, create space, stay safe. What next?
Step 2. Stay calm and neutral. Don't argue back, don't get defensive, don't take insults personally. Your calm presence can help diffuse the situation.
Don't feed the fire.
Exactly. Step 3. Lower your voice. Speak calmly, softly, and slowly. A raised voice escalates things. A quiet voice can be surprisingly calming. Try to listen to their concerns, even if they're expressed angrily. Try to figure out the trigger pain, fear, frustration.
And they get the nurse, presumably.
Absolutely. Your goal is to keep everyone safe and try to bring the tension down until help arrives. Don't try to handle a truly combative situation alone.
That makes sense. And handling these situations well requires those core interpersonal qualities: empathy, good interpersonal skills, and patience.
For sure, empathy is trying to understand things from the resident's perspective, to feel with them, not just for them. That's sympathy. Validate their feelings even if you don't agree with their behavior. I can see you're very upset right now.
And good. Interpersonal skills are just how you relate to people effectively. Being respectful, courteous, communicating clearly.
Yes, and adapting your communication. This is key for residents with special needs, which the test covers. If someone has a hearing impairment, what do you do?
Face them directly, speak clearly, and maybe a bit slower, Lower the pitch slightly, reduce background noise, don't shout, use short sentences, maybe gestures.
Right, or for vision impairment.
Announce yourself when you enter, explain what you're doing before you touch them, keep things in predictable places, use the clock face method to describe food location.
Perfect. And all of this takes patience. Residents might move slowly, speak slowly, or need things repeated. You have to remain calm and unhurried. Rushing them increases anxiety and the risk of accidents.
Okay, that covers the people skills. Now for the microscopic battlefield, Section 3. Infection control and asepsis. Terms 19 through 38. This feels like a big one for the test.
Huge. Foundational. Let's start with the players. Microorganism, infection, pathogens, bacteria, communicable, and nosocomial.
Microorganisms. Tiny living things, right, everywhere. Some good, some bad.
Exactly. The bad ones, the disease-causing ones, are called pathogens. When pathogens invade the body and multiply, causing illness, that's an infection.
And bacteria are just one type of pathogen.
A very common type, yeah. Single-celled organisms. Many bacterial infections can be treated with antibiotics, which we'll get to.
Okay, what about communicable?
That means the disease can be spread from one person to another. Think the flu, a cold, tuberculosis, TB. If a disease is communicable, we need specific precautions to stop the spread.
Like if a resident has TB, which spreads through the air, they might be in isolation and you'd need a special mask.
Precisely. And that brings us to nosocomial infections. This is a really important term.
Nosocomial. Sounds technical.
It means an infection that is acquired while in a healthcare facility. The resident didn't have it when they came in, they picked it up there.
Wow. So preventing those is a major goal of all these procedures.
Absolutely. Things like infection control prevention measures and medical asepsis.
Infection control is just the overall effort to stop germs from spreading.
Yep. It's a whole system of practices. A key part of that is medical asepsis, also known as clean technique. It means practices used to reduce the number of microorganisms and prevent their spread.
Like hand washing.
Hand washing is the cornerstone, but also cleaning equipment, handling linens properly, not working when you're sick. It's about keeping things clean to reduce pathogen transmission.
Got it. And you mentioned antibiotics and antisepsis earlier.
Right. Antibiotics are drugs that kill bacteria inside the body. Antisepsis is using chemicals to kill germs or slow their growth on skin or other living tissue. Think of iodine or alcohol wipes used before an injection. It reduces germs on the surface.
Okay, clean technique for people. Now, what about protecting ourselves and handling contaminated stuff? That must be standard precautions.
Exactly. Subsection 6, standard precautions and PPE. Key terms here are standard precautions. Biohazard, contamination, disinfection.
So standard precautions. What's the absolute core concept the test wants you to know?
Treat all blood, body fluids, secretions, excretions, except sweat, non-intact skin, and mucous membranes as potentially infectious for every resident.
Every single one, even if they seem perfectly healthy.
Every single one, every single time. You cannot tell who has an infectious disease just by looking. Assume everyone could be a source, protect yourself accordingly. That's the heart of standard precautions.
And if you encounter something visibly soiled with blood or body fluids, like bloody gauze or soiled linens,
that material is considered a biohazard. You handle it carefully, wearing gloves, contain it properly, usually in specially marked bags or containers, to prevent contamination.
Contamination just means spreading germs from a dirty surface to a clean one.
Or person, yes, like touching a contaminated bed rail and then touching a clean wound dressing without changing gloves or washing hands.
And what about cleaning those surfaces, like the bed rail or overbed table?
That's where disinfection comes in, using chemical solutions to kill pathogens on surfaces and equipment. It kills most germs, but not necessarily bacterial stores. It's different from sterilization.
Got it. Now, the tools we use for standard precautions: personal protective equipment, PPE, especially gloves, and the number one weapon, hand washing.
Let's start with the MVP, hand washing. If the test asks for the single most important thing you can do to prevent infection spread,
it's hand washing, always.
Always. And how long do you scrub? Minimum.
20 seconds. Vigorous scrubbing with soap and water. Friction is key.
Perfect. Alcohol-based hand rubs are good too, but soap and water are needed if hands are visibly soiled or after caring for someone with C. diff. Now, PPE.
Gloves, gowns, masks, goggles, or face shields.
Right. You wear PPE whenever there's a risk of exposure to blood or body fluids. Gloves are the most common. Wear them for mouth care, perineal care, handling soiled items, contact with broken skin or mucous membranes.
And the order for putting it on and taking it off matters, right? Especially taking it off.
Critically important to avoid contaminating yourself. The general order for donning, putting on, is often gown, then mask respirator, then goggles face shield, then gloves go on last, over the cuff of the gown.
But taking it off doffing is where the risk is.
Exactly. You remove the most contaminated items first. Usually it's gloves first, then goggles face shield, then the gown, then the mask last. And what do you do immediately after removing all PPE?
Wash your hands or use hand sanitizer.
Always. Final piece here. The sharps container.
For needles, razors, anything sharp that could puncture the skin.
Yes. They go immediately into a designated puncture-resistant, leak-proof, labeled sharps container. Never, ever try to recap a used needle. Never bend or break needles. Drop them straight into the container. That prevents needle stick injuries.
Okay, lots of detail there, but super important. We've covered microscopic threats. Now let's talk about larger-scale physical safety in Section 4. Safety, movement, and injury prevention. Terms 39 to 45.
Right. Protecting yourself and the resident from physical harm, starting with body mechanics and body alignment.
Body mechanics. This is about using your body correctly when lifting and moving things to avoid injuring yourself, especially your back.
Exactly. Safe lifting techniques. And body alignment is about keeping the body, yours or the resident's, in a straight line with good posture, providing support to maintain curves of the spine, prevent strain.
What's the absolute must-remember rule for lifting that always shows up on tests?
Okay, picture this. You need to lift a somewhat heavy box or help a resident move up in bed. What do?
Get close to the object or person, spread my feet shoulder-width apart for a stable base.
Good start. Then what? Bend your back.
No, bend my knees and hips, keep my back straight, use my leg muscles, big thigh muscles to do the lifting.
Bingo. Keep the object close to your body. Avoid twisting while lifting. If you need to turn, pivot your whole body with your feet. Following those rules protects your back.
Okay, knees bent, back straight, use legs, keep it close, no twisting. Got it. Now what if the resident needs help moving, like walking or transferring, and they're weak?
Then you use a gait belt, sometimes called a transfer belt.
That sturdy belt that goes around their waist.
Yes. You put it snugly over their clothing, around their waist. Make sure you can get a couple of fingers under it. You grasp it from underneath with both hands, usually towards the back or sides.
And that gives you a secure hold to support them.
Exactly. It helps you control their movement safely during transfers, like bed to chair or while walking, ambulating. If they start to lose balance, you have a firm grip on their center of gravity, not pulling on their fragile arms.
Makes sense. Reduces risk for both of you. Now let's talk about common accidents, specifically falls and burns, and the call light.
Falls are the most common accident in healthcare settings. Prevention is constant.
What are the key prevention steps the test emphasizes?
Keep floors clean, dry, and free of clutter. Ensure adequate lighting. Make sure residents wear non-skid footwear. Lock bed wheels and wheelchair wheels before any transfer. Keep pathways clear. Answer call lights promptly.
Okay, prompt call light response is huge. And always make sure it's within the resident's reach, right? Usually on their stronger side.
Always within easy reach. It's their lifeline for help. Now, what if, despite all precautions, a resident starts to fall?
Ah, the trick question. Don't try to catch them or stop the fall.
Correct. You could injure yourself badly, and them too. Instead, you control the fall. Widen your stance, bring the resident's body close to yours, and gently lower them to the floor, maybe sliding them down your leg. Protect their head, then stay with them and call for help immediately.
Got it. Assist to the floor, don't catch. What about burns? Mostly from hot liquids.
Scalds from hot liquids are common, yes. Also burns from heating pads or equipment. Prevention is key. Always check water temperature before bathing or showering. Use a thermometer or the inside of your wrist.
And with hot drinks.
Warn the resident it's hot. Keep mugs away from the edge of the table. Use lids if possible. Be careful with hot packs. Make sure there's enough padding.
Okay, makes sense. Constant vigilance. Now, moving to non-medical emergencies in subsection 8, choking and fire safety.
First, choking. Airway blockage. If someone is eating and starts coughing forcefully...
Let them keep coughing. They're still moving air. Encourage them.
Right. But if the coughing becomes weak or silent, if they can't speak, breathe, or cough, and especially if they make the universal choking sign, hands clutching the throat...
Like a complete blockage.
Yeah.
Act immediately. Abdominal thrusts. The Heimlich maneuver.
Yes. Get behind them, wrap your arms around their waist, make a fist, place it thumb side against the abdomen just above the navel, grasp your fist with your other hand, and give quick upward thrusts.
Until the object pops out or they lose consciousness.
Correct. If they do become unconscious, you lower them to the floor and start CPR, beginning with chest compressions and checking for the object in the mouth before giving breaths. Knowing the difference between partial and complete obstruction is key for the test.
Okay. Now, fire safety. There's an acronym.
RACE. You absolutely need to know this sequence for the exam.
R, remove residents from immediate danger. Get people out of the room first.
Correct. Safety first.
Aber.
Yeah.
Activate the alarm. Pull the fire alarm. Call 911 or follow facility procedure. Alert everyone.
Good. C.
Contain the fire. Close doors and windows to slow the spread of smoke and flames if it's safe for you to do so.
Right. Don't put yourself in danger. And E.
Extinguish the fire, but only if it's small, you know how to use the extinguisher, and it's safe. Otherwise, evacuate and let the fire department handle it.
Perfect. They often ask sequencing questions about RACE, like after you activate the alarm, what's next? Usually containing the fire by closing doors.
Okay, RACE. Got it. Now for the really serious stuff. Section 5. Medical emergencies, terms 46 to 57.
High stakes here. Rapid response is crucial. Let's start with the basics. First aid, cardiac arrest, CPR, unconscious, and cyanotic.
First aid is just that immediate care you give before professional help arrives.
Exactly. Temporary help for injury or sudden illness. Now, if someone's heart stops beating completely, that's cardiac arrest.
And that requires CPR, cardiopulmonary resuscitation.
Yes. Chest compressions and rescue breaths to circulate blood and oxygen. Big caveat here. NAs must know their facility's policy. Are you allowed and expected to start CPR, or is your role strictly to call for help like a code blue and assist the nurse emergency team? Never go outside your scope of practice.
Okay, that's critical. Always follow facility policy on CPR initiation. What if you find someone unresponsive? That's unconscious.
Yes, not awake, not responding to voice or touch. You need to assess the situation quickly. Check for breathing. Look for signs of poor oxygenation, like cyanotic skin.
Cyanotic, that's the bluish or grayish color. Lips, nail beds.
Yes. It means lack of oxygen in the blood. It's a critical sign. If you see cyanosis, you need help immediately. Yell for the nurse.
So the general emergency steps are: check the scene for safety, check the victim for consciousness, call for help loudly, stay calm, and provide care only within your training and scope until help arrives.
That's the sequence. Get help rolling first. Documentation comes way later.
Okay. Now for specific life-threatening events, subsection 10.
Yeah.
Heart attack, seizure, and stroke. Let's start with heart attack. Myocardial infarction, or MI. What happens?
Blood flow to part of the heart muscle gets blocked, usually by a clot. That part of the muscle starts to die from lack of oxygen.
What are the classic signs?
Sudden, severe chest pain or pressure, often described as crushing, squeezing, or like an elephant sitting on the chest. It might radiate to the left arm, neck, jaw, back, or even the stomach.
Any other signs? Like difficulty breathing?
Yes. Shortness of breath or dyspnea is common. Also nausea, vomiting, sweating, dizziness, extreme anxiety, or a feeling of impending doom.
Now, you mentioned earlier women might have different symptoms. The test might focus on this.
Absolutely a critical distinction. Women often don't have that classic chest pain. Their symptoms can be much vaguer.
Like what?
Extreme, unusual fatigue, shortness of breath, dizziness, pain or discomfort in the back, neck, jaw, or abdomen, sometimes mistaken for indigestion or heartburn. Flu-like symptoms. If you only look for chest pain, you could miss an MI in a woman. Report any of these sudden symptoms immediately.
Wow, okay. Good heads up. Next emergency, seizure. What's happening in the brain?
It's like a sudden, uncontrolled electrical storm in the brain. It causes involuntary muscle contractions, changes in consciousness, or sensory disturbances.
What does it look like? The severe shaking, thrashing limbs, maybe jaw clenching?
That's a common type, yes, a generalized tonic-clonic seizure. But seizures can manifest differently. Some might just stare blankly or have brief muscle twitches.
If someone has a major seizure, what's the caregiver's main goal?
Safety. Protect them from injury. Ease them to the floor if they're standing. Move furniture or hard objects away. Place something soft, like a folded towel, under their head. Loosen tight clothing around the neck.
And what should you absolutely not do?
Never try to restrain their movements, and never, ever force anything into their mouth. No bite sticks, no fingers. They could bite down, break teeth, or aspirate. Just keep them safe and time the seizure if you can. Call for the nurse immediately.
Okay. Protect, don't restrain, don't put anything in the mouth. What about after?
They might be confused, sleepy, or disoriented afterward. Stay with them, reassure them, check for injuries, and report your observations to the nurse, how long it lasted, what body parts were involved.
Got it. Final big one, stroke or CVA. Cerebrovascular accident. What's the cause?
Blood supply to part of the brain is suddenly interrupted, either by a clot, ischemic stroke, or bleeding, hemorrhagic stroke. Brain cells start dying within minutes. Time is critical.
So recognizing the signs instantly is key. There's an acronym for this too, right?
Yes, FAST, extremely important for the test. F is for face drooping. Ask the person to smile. Does one side of the face droop or look uneven?
Okay, F for face. A.
A is for arm weakness. Ask them to raise both arms. Does one arm drift downward or feel numb? S is for speech difficulty. Ask them to repeat a simple sentence like, "The sky is blue." Is their speech slurred? Are they unable to speak? Do they use the wrong words?
And T.
T is for time. Time to call 911 or activate emergency response immediately if you see any of these signs. Note the time the symptoms first appeared.
FAST, face, arm, speech, time. Got it. And what's the critical do not do for a potential stroke victim?
This is a high miss area. Do not give the person anything to eat or drink. MPO, nothing by mouth.
Why not?
The stroke might have affected their ability to swallow safely, dysphagia. Giving them food or liquids could cause them to choke or aspirate into their lungs. Report the signs immediately, ensure help is coming, and keep them NPO.
Okay. FAST and MPO. Critical takeaways for stroke. We've covered some intense emergencies. Let's move to the final section. Section 6. End-of-life care. Terms 58 to 69.
A very different focus here, shifting from emergency intervention to comfort and support, starting with terminal illness, dying, and death and dying.
Terminal illness just means an illness or condition that doctors expect will eventually cause death. There's no cure.
Correct. Focus of care changes. The process of dying involves physiological changes as the body systems begin to shut down.
What kind of changes might an NA observe?
Things like decreased circulation, so the hands and feet might feel cool, skin might look mottled or purplish. Breathing patterns might change, becoming irregular or shallow. Decreased appetite and fluid intake, increased sleeping, or decreased responsiveness.
So the NA's role becomes about providing comfort, managing symptoms, and respecting the resident's dignity during this time.
Absolutely. Pain management, frequent repositioning for comfort, good mouth care because the mouth can get very dry, listening, providing emotional and spiritual support if requested.
This type of care often falls under palliative care or hospice. What's
Yeah.
the difference? The test might ask.
Good question. Palliative care is focused on comfort, symptom relief, and improving quality of life for people with any serious illness at any stage. It can be given alongside curative treatments.
Okay, so palliative is about comfort, maybe alongside treatment. What about hospice?
Hospice is a specific type of palliative care for people who have a life expectancy of 6 months or less, as certified by a doctor, and they are no longer seeking curative treatment. The focus is entirely on comfort, dignity, and quality of life for the time remaining.
So hospice is for the final stages when cure isn't the goal anymore.
Generally, yes, it's a philosophy of care and often a specific insurance benefit. Now, during this time, everyone involved, resident, family, even staff, might go through the stages of grief or the grieving process.
The famous 5 stages. Denial, anger, bargaining, depression, acceptance.
Those are the classic stages identified by Elizabeth Kubler-Ross. Denial, this can't be happening to me. Anger, why me? This is unfair, often directed at others. Bargaining, if I just do this, maybe I'll get more time. Depression, sadness, withdrawal, hopelessness. Acceptance, coming to terms with reality, often a peaceful stage.
It's important to remember people don't always go through them in order, right? They can bounce around.
Exactly, and not everyone experiences all stages. The key for the NA is to recognize these are normal reactions to loss. If a resident or family member is angry, don't take it personally. Try to understand it's part of their grief. Offer support. Listen non-judgmentally. Be patient and empathetic.
It makes sense.
Right.
Okay, last subsection. Legal directives. Terms like advance directives, living will, and DNR.
Very important legal concepts. Advance directives are legal documents that allow a person to state their wishes about future healthcare decisions in case they become unable to speak for themselves.
Like if they become unconscious or develop dementia.
Right. There are different types. A living will is one type where a person outlines specific medical treatments they do or do not want, like mechanical ventilation or tube feeding, life support.
Okay. And DNR.
DNR stands for Do Not Resuscitate. It's a specific medical order written by a doctor based on the resident's wishes, often stated in an advance directive, instructing healthcare providers not to perform CPR if the resident's heart stops or they stop breathing.
So if a resident has a valid DNR order and they go into cardiac arrest.
You do not start CPR. You provide comfort measures, alert the nurse, but you respect their documented wish to avoid resuscitation. Knowing a resident's code status, full code versus DNR, is absolutely essential.
Respecting their rights and wishes is paramount. What about after death occurs? Terms like life support, postmortem care, and rigor mortis.
Well, life support refers to machines like ventilators or dialysis that keep bodily functions going when organs fail. Decisions about withdrawing life support are complex and based on advanced directives and family discussions, not typically an NA's decision.
Right. But after death, NAs are often involved in postmortem care.
Yes, this is the physical care of the body after death, performed with dignity and respect. It involves gently washing the body, putting on a clean gown, positioning the body naturally, and preparing it for the family to view or for transport to the morgue or funeral home.
Is it important to do this relatively quickly? Because of rigor mortis.
Yes. Rigor mortis is the natural stiffening of the body's muscles that begins several hours after death. Performing postmortem care before rigor mortis sets in makes positioning the body easier and more natural looking. It's the final act of care for that resident.
Okay. A lot to cover in Chapter 2, but incredibly important foundations.
Absolutely. Communication, safety, infection control, emergencies, end of life. It's the core of compassionate, competent care.
We really unpack those key terms, trying to give you not just the definition, but the why behind it for your Headmaster Test prep. We looked at objective versus subjective, the RACE acronym, FAST for stroke.
The importance of hand washing, standard precautions for everyone, knowing when to report immediately, understanding body mechanics, these are the details that make the difference on the exam and in practice.
So as you keep studying, we want to leave you with one final thought, kind of tying back to our very first points on communication. Yeah. We talk about spotting conflicts between verbal and nonverbal cues.
Right, like when someone says, "I'm fine," but looks terrified.
Exactly. We also touched briefly on adapting communication for hearing or vision impairment. But let's go a layer deeper. Think about culture.
Ah, yes. Culture adds a whole different dimension to interpreting nonverbal cues.
So the challenge for you is this. When you're interacting with your next resident, go beyond just listening to their words or noticing basic body language. Ask yourself, how might their cultural background affect how they communicate nonverbally?
Think about things like eye contact. In some cultures, direct eye contact is respectful. In others, it's considered rude or challenging, especially towards authority figures. Or personal space, how close is comfortable.
Or touch. Is a comforting touch on the arm welcome? Or is it an invasion of privacy or culturally inappropriate? If a resident avoids eye contact or seems distant, is it withdrawal? Or is it a cultural norm you need to respect?
How can you adjust your communication, your eye contact, your proximity, your use of touch to build trust and truly connect, respecting their cultural background? It's about seeing the whole person.
Something to really reflect on as you prepare. How does culture influence care? Think about that.
Good luck with your studying. You've got this. And join us next time for Part 3.
Welcome to Part 3 of our Key Terms Deep Dive series for the Headmaster Test Prep. This is just one segment of our full 10-part guide, so stick with us.
We're diving deep today.
Our goal today is to tackle Chapter 3, which is really critical vocabulary. It's all focused on understanding resident needs and behavior.
Yeah, I'd say this is arguably one of the most important deep dives for passing the Headmaster Test, especially those scenario-based questions, We're really zeroing in on terms that pop up frequently, and maybe more importantly, those ones that are notorious for a high miss rate.
Right.
So if you're a recent graduate, you're gearing up for your certification, these concepts, they really define what person-centered care actually means in practice.
Absolutely. And that's what we're going to do. We'll give you simple definitions, kind of unpack the why behind these terms, and run through those exact real-world scenarios you're likely to see on the exam.
Let's do it.
Okay, no time to waste. Let's jump straight into the foundations of, well, empathetic care.
Okay, so let's start with the real groundwork of personalized care. First essential concept, culture.
Yeah, culture. It's way more than just like language or where someone grew up.
Right, totally. It's those deep-seated beliefs, the customs, traditions, all the learned behaviors from someone's background.
And these directly affect their daily life and, crucially for us, their care preferences. So when you see this term on the test, the application, it's always about respect.
Exactly. The test really wants to confirm that you get it, that NAs have to adjust their care. You meet the resident's specific, culturally driven needs. You never, ever impose your own wishes or what's convenient for you.
That's the core difference, isn't it, between just doing tasks and actually providing person-centered care.
Spot on.
And you got to think specifics. Culture influences things like preferred physical space. Some cultures are fine being close, others really need more distance.
Right. And it affects the food they eat, how they might show distress, even the clothes they prefer to wear. It's broad.
It really is.
Yeah.
And this connects deeply to religious practices, too, and dietary rules.
Oh, definitely. Like, the test might throw a scenario at you involving a resident who keeps kosher, or maybe someone who fasts during Ramadan or Lent.
So what's your role?
Your role is absolute respect. You need to know the basics, maybe not serving meat and dairy together for kosher, or ensuring quiet time for prayer, and then accommodating those needs within the facility's policy.
And this brings us to a really important point, a high-miss area, actually, those prohibitions.
Yeah.
Because care is so personal, it's easy to feel close to residents, maybe want to share your own life stuff.
But you just can't. You must never try to change someone's religion, never express judgments about their beliefs, and definitely don't start discussing your own personal religious views or political opinions.
Those are serious boundary violations, right? It kind of strips away that safe space for the resident.
Absolutely essential boundary to remember for the exam. Okay, let's shift gears. A topic loaded with potential test pitfalls, the aging process.
The aging process,
Okay.
defined by those predictable physical changes that happen over time. And I think the key word there is predictable, right?
That's exactly it. So what does that look like, physically speaking? Well, skin tends to get thinner, drier, less elastic. It becomes much more prone to tears and bruises. Muscles, they can get weaker, less toned, which leads to less stability, maybe less strength. Bones become less dense, so the risk of fractures goes up.
Digestion slows down, elimination too.
Right. And a big one, healing takes much longer. A small cut that might heal in days for a younger person could take weeks for an older adult.
Okay, so here's the critical high-miss area. This is where the test tries to, trip you up. Recognizing what's normal aging versus what's abnormal.
Yes, this is huge. The test loves to give you a symptom and ask, should you report this immediately?
So an older resident, maybe they tire easily after a short walk, or they take a little longer to grasp new instructions.
That's usually expected. It's typically a normal change associated with aging. Nothing alarming there, usually.
But the moment you see a sudden change,
Right.
or something really abnormal.
That's the trigger. Report it immediately. No hesitation.
So what counts as abnormal? Give us some examples.
Okay, think sudden, rapid weight loss for no clear reason, new chronic incontinence when they were continent before, severe shortness of breath that wasn't there yesterday, sudden acute confusion, or deep persistent psychological issues like severe depression or, talk of suicide.
So it's about a significant change from their baseline, their usual state.
Exactly. If they've been moving slowly for 6 months, that's their normal now. But if they were perfectly fine yesterday and today they're suddenly non-responsive or crying uncontrollably, that's abnormal. That needs a nurse. Stat.
Got it. That distinction feels really key for this chapter. Normal slowing versus rapid decline.
Nail that, and you've mastered a big chunk of this concept for the test.
Okay, moving from the physical side to more philosophical concepts. Let's define basic needs.
Basic needs. These are just the essential requirements for human life. Things everyone needs. Food, safety, love, acceptance, dignity.
Right. And we often use models to sort of organize these.
Yeah.
Maslow's hierarchy of needs is the famous one.
Yeah, let's touch on Maslow quickly, because the idea of holistic care flows right out of it.
Okay. So at the bottom of Maslow's pyramid, you have the most urgent needs. The physiological needs.
Yeah.
That's air, water, food, sleep, shelter. The absolute basics for survival.
Once those are pretty much met, you move up to safety needs, feeling secure, financially stable, healthy, safe from harm.
Then comes love and belonging. That covers friendship, family, intimacy, feeling connected.
Higher still is esteem. This is about dignity, self-respect, feeling competent, having independence.
And right at the very top is self-actualization. That's reaching your full potential, whatever that means for the individual.
And this pyramid, this hierarchy, leads us straight into the core concept for Chapter 3, holistic care.
Holistic care, meaning?
Meaning caring for the whole resident, not just the body, but everything. Addressing both those physiological needs, the base of the pyramid, like food, water, activity, sleep, and just as importantly, their psychosocial needs.
Which are those upper layers?
Yeah.
Love, acceptance, safety, self-esteem, independence.
Exactly. So it's not enough just to make sure the resident eats their lunch. Okay, that meets a physiological need. Great.
But holistic care goes further.
It does. It means ensuring the resident feels respected while eating, Maybe encouraging them to use the fork they prefer or letting them choose where they sit to eat, if possible.
And when those higher-level psychosocial needs aren't met, that's when you see problems.
Big problems. Strong negative feelings start to surface. Frustration, anxiety, withdrawal, even depression. And these feelings directly interfere with their physical health. It's all connected. Okay, so we have this holistic framework. Now let's look at how these needs actually show up in daily care. Starting with the most immediate, physical needs.
Physical needs
We do.
cover the body basics, right?
Yeah.
Good nutrition, keeping clean with hygiene, getting regular exercise or movement.
Yep. These are the needs we're constantly addressing through ADL's activities of daily living. Things like helping with eating, bathing, dressing, toileting.
And you mentioned activity. That seems particularly important here.
Oh, it's absolutely crucial. The need for activity, immobility, just not moving enough, is like a recipe for disaster, especially in older adults.
Huh.
When residents are inactive for long stretches, we see really profound negative consequences. And these are frequently tested scenarios, so pay attention here.
Let's unpack those consequences, because the exam wants you to understand the why. Why does inactivity cause something like pneumonia?
Good question. Well, when you're immobile, breathing tends to become shallow. Fluid and secretions can pool in the lungs because the person isn't moving around enough to clear them effectively.
And that pooled liquid.
Becomes a perfect breeding ground for bacteria, hence pneumonia.
Makes sense.
What else? Similarly, inactivity drastically bumps up the risk of urinary tract infections, UTIs. The bladder might not empty completely when someone's not moving much.
Okay.
It causes severe constipation. And, of course, skin breakdown and pressure injuries are a huge risk because circulation is poor and there's constant pressure on bony spots.
And blood clots too, right?
Definitely. High risk of blood clots due to that poor circulation. And those can be fatal if they travel.
Wow. So encouraging a resident to just walk down the hall, even slowly,
Yeah.
or helping them change position every couple of hours, that's not just busy work.
Not at all. It's literally preventative medicine. It guards against serious illness. Plus, activity boosts mood, improves concentration, helps with sleep and appetite. It keeps all the body systems working better.
Okay, really important connection there. Moving up Maslow's pyramid now, emotional needs.
Emotional needs. This is about support for those deep feelings, fear, loneliness, sadness, but also joy and the need for acceptance.
And you flagged this as a massive high-miss area on the test. Why?
Because it involves responding with empathy, not just performing a task. Many are trained heavily in physical tasks, but responding effectively to emotion requires, well, emotional intelligence, a soft skill.
Okay.
So when a resident shows strong negative feelings, stress, anxiety, maybe they withdraw, it seriously messes with their motivation and their overall health.
So the test will give a scenario. Like,
It's a classic one.
okay.
If a resident is crying, what is the NA's immediate and correct response?
And the answer is?
Always. Listen quietly, acknowledge their distress without judging, and then report it to the nurse.
What not to do?
Do not interrupt them. Do not try to fix whatever the problem is yourself. And definitely, absolutely never tell them to cheer up or stop crying.
Why not?
Because simply listening and acknowledging validates their feelings. It meets their emotional need for acceptance and support in that moment. Trying to shut it down does the opposite.
Got it. Listen. Acknowledge, report.
Huh?
Okay, next up. Social needs.
Social needs.
Yeah.
Pretty straightforward. It's the basic human need for interaction, for friendship, for feeling like you belong, like you're part of a group.
And in a healthcare setting, how does this usually play out?
It really highlights the importance of the resident's family, and family here is defined very broadly.
Right, not just the traditional nuclear family.
Exactly. Nuclear, blended families, extended families, same-sex couples, opposite-sex partners, whoever the resident considers their core support system, that's their family.
And what role does family play?
A huge role. They provide that vital connection to the outside world, help the resident maintain their sense of identity, often assist with big care decisions, and offer reassurance, especially when someone is facing serious illness or end of life.
So as an NA, what are your responsibilities regarding family?
Your job is mainly to facilitate that connection. You absolutely must allow privacy for family visits. Knock, wait, give them space.
Okay.
Communicate professionally and respectfully with them, of course. And critically, observe and report any effects those visits might have on the resident.
Positive or negative?
Both. If a resident seems really happy and energized after a visit, that's good info. But if they're consistently upset, maybe crying or agitated after a particular person leaves, that's crucial information for the care team to know.
Okay, makes sense. Now let's talk about spiritual needs.
Spiritual needs. This involves things like faith, prayer, finding meaning, or purpose in life. Your role is to support these needs without imposing your own views or judgments.
And this area seems to have some very specific do's and don'ts for the test.
It really does. Highly technical questions pop up about the NA scope of practice here. Let's break down what you are permitted to do.
Well,
You can definitely encourage residents to participate in spiritual activities offered by the facility if they're interested. You must allow privacy for visits from clergy members, priests, rabbis, ministers, etc.
can you read religious texts?
Yes, if the resident asks you to, you can read religious materials aloud if they request it. You're there to help facilitate their practice.
Okay, now the prohibitions,
Yeah.
the hard lines. What can nays not do?
Right, the big don'ts that get tested. You are not permitted to try and change someone's religion, period.
Okay.
You can't tell residents their beliefs are wrong. You can't express judgments about any religious group. You shouldn't insist residents join activities that might conflict with their beliefs.
And the personal stuff again.
Right. Again, absolutely no discussing your own personal religious beliefs or your political opinions. You are a professional caregiver, not a missionary or a campaign worker. Keep it professional.
Got it. Crystal clear. Finally, in this needs section, sexual needs.
Sexual needs. These are those private desires for affection, intimacy, connection. And the key point here, they absolutely remain throughout the entire lifespan, including old age.
This feels like an area where societal myths are really strong.
Incredibly strong. And the Headmaster Test actively tries to debunk them. The facts are pretty clear. Many older men continue to have satisfying sexual relationships, even if things change physically.
And women.
Many women, sometimes relieved of pregnancy worries after menopause, actually report enjoying sex more in their later years. That fundamental human need for intimacy, it doesn't just vanish when you hit 65 or 75.
So for the NA, what's the core principle?
Non-judgmental respect and ensuring absolute privacy. Always, always knock and wait before entering any residence room, even if you think they're asleep or alone. Assume privacy is needed.
And what about that classic scenario, the Mr. and Mrs. Brown situation?
Yes. The case study where you might walk in on a consensual sexual situation between residents or a resident and their visiting spouse.
What's the action?
Your action is immediate and professional. You apologize quietly, you close the door gently, and you provide privacy. That's it.
No reacting.
No gawking, no giggling, no making jokes later. You don't make a big deal out of it. You would report the observation to the nurse just as a routine matter to ensure safety, but without any judgment attached.
And this respect extends to all identities.
Absolutely. You must respect every resident's sexual orientation and gender identity. Use their preferred names and pronouns, always.
The bottom line seems to be dignity.
Total dignity. Expressions of sexuality by older adults, they should never be viewed as weird or cute or disgusting. It's just a fundamental part of who they are as human beings.
Okay, shifting gears now. We're moving into territory where care can get, well, more challenging, managing difficult behaviors. Let's start by defining behavior itself.
Behavior, yeah. It's simply how a resident acts. It can range from perfectly calm and cooperative to, agitated or aggressive.
Okay.
But crucially, in a healthcare setting, we need to view a resident's behavior primarily as a form of communication.
Communication. How so?
Well, when that behavior changes, especially if it turns negative, like yelling, refusing care, hitting the NA's very first duty isn't to react defensively, it's to pause and try to figure out the cause. Why are they acting this way?
And this is another one of those major high-miss areas you mentioned.
Huge, because the cause is almost never just malice or being difficult. It's almost always rooted in something else. Pain, fear, deep frustration from losing independence, an unmet physical need like hunger or needing the toilet.
They can't always tell you directly, I feel powerless and scared, so maybe they lash out instead.
Exactly. Once you understand that behavior is communication, your whole response strategy changes.
So sometimes the behavior might be something like agitation.
Right. Agitation is that restless activity, pacing back and forth, fidgeting constantly, maybe pulling at clothes. It often stems from physical discomfort, confusion, anxiety, or even needing to use the bathroom and not being able to express it.
Okay. And then there's a more serious term, the combative resident.
Yes, combative. This means a resident who physically fights back, hitting, kicking, biting, scratching, pushing.
And the key thing to remember here is
You absolutely must internalize that this behavior usually comes from fear or pain made physical. They are likely terrified, confused, or insignificant physical pain, and this is how it's coming out.
So the test answer for how to respond needs to reflect de-escalation.
Absolutely. First step. Look for that underlying cause. Are they grimacing in pain? Is a catheter tube pulled tight? Is the room too noisy and chaotic?
You don't restrain them.
No, not unless you are specifically trained and authorized by the facility for a specific, dangerous situation. Instead, you maintain a safe distance. Speak in a very low, calm, soothing voice. Try to gently redirect or calm them before immediately reporting the behavior to the nurse. Safety first, always.
Okay. Then we also have anxiety. How's that defined?
Anxiety is that excessive worry or fear. It can make a resident seem restless, irritable, maybe have trouble sleeping or eating. It often goes hand in hand with the huge losses they experience when moving into a care facility.
And this anxiety can sometimes manifest as what we might call a demanding resident.
That's often the case. The demanding resident, the one who asks for a lot of attention, uses the call light constantly, maybe makes requests that seem unreasonable.
But we need to look deeper than just demanding.
Exactly. We have to recognize this behavior usually stems from profound feelings of loss. Loss of their home, their health, their mobility, their friends, their independence, and especially that feeling of competence, of being useful. They feel helpless and maybe scared.
So the test really focuses on the appropriate NA action for this resident.
Heavily. You have to resist that natural urge to maybe ignore them or, worse, treat them like a child. Infantilize them.
So what do?
You promote their independence fiercely, encourage them to do as much as possible for themselves, even if it takes way longer. Be patient. Allow them to make choices whenever feasible, what to wear, when to bathe if policy allows.
Never treat them like children.
Never, ever. Infantilization just strips away their dignity, makes them feel even more useless, and usually makes the demanding behavior worse. Choice and control are incredibly powerful tools.
Okay. Shifting back to a physical symptom for a moment. Dizziness.
Dizziness, right.
Yeah.
That feeling of being unsteady, maybe like the room is spinning. It's important to report this immediately because it's a major risk factor for falls.
And it could signal underlying issues.
Could be low blood pressure, dehydration, maybe an inner ear problem, medication side effect. Lots of possibilities the nurse needs to check out.
Okay. And lastly in this section, defense mechanisms.
Defense mechanisms. These are those unconscious ways people kind of protect themselves from emotional pain when reality feels too hard to cope with directly.
And the sources often mention one specific type.
Yes, regression. This is a high miss term, so make sure you know it.
Regression. What does it mean?
It means reverting or going back to an earlier, less mature state of behavior as a coping strategy under stress.
Like what? Give an example.
Okay, maybe an adult resident who's usually independent is facing a stressful family visit. Suddenly, they might start refusing to eat unless you spoon feed them, like a child. Or they might throw a full-blown temper tantrum over something small, something they'd normally handle fine.
So recognizing it as a defense mechanism helps you react differently.
Exactly. It helps you respond with patience and understanding, looking for the underlying stress, rather than just getting frustrated with the seemingly childish behavior. All right, this section is critical. Cognitive decline. This stuff is guaranteed high-frequency test material. We need to be really precise with our definitions here. First up, a confused resident.
Confused resident. So this is someone who has trouble thinking clearly, right? Maybe makes poor decisions, has difficulty processing new information.
Exactly. And the important thing is, confusion can be caused by chronic issues like dementia, but it can also be caused by acute problems, like a urinary tract infection, a high fever, a reaction to a new medication, dehydration, even constipation. So it's really important to investigate the cause because acute confusion can often be treated and reversed.
Okay. And if that confusion specifically involves losing track of basic situational awareness,
then they are disoriented. That means they don't know the time or where they currently are, or maybe they don't recognize the people around them, even familiar staff. They're essentially lost in reality.
and a core part of many cognitive issues is memory loss.
Memory loss, yeah. Defined generally as forgetting things, especially recent events. In conditions like Alzheimer's disease, short-term memory typically goes first.
So they might ask the same question over and over.
Exactly. They genuinely don't remember asking it 5 minutes ago. But interestingly, their long-term memory things from their childhood, old jobs, major life events might remain surprisingly intact for quite a while.
We also have the term drowsy.
Drowsy. Simply feeling sleepy or lethargic often just indicates fatigue, but it must be reported.
Why?
Because it could be a sign of overmedication or maybe a worsening infection or illness. Needs checking out.
Okay, now the big one. Dementia.
Dementia. This is a progressive and sadly irreversible loss of brain function. It affects memory, thinking skills, language, judgment, and behavior.
And the crucial distinction for the exam.
Dementia is not curable. It is progressive, meaning it will inevitably get worse over time, although supportive care and some medications can help manage the symptoms. This permanent, progressive nature dictates our entire approach, especially communication.
And within dementia, there's a specific behavioral symptom called sundowning.
Sundowning, yes. This is when a person's confusion, restlessness, or agitation gets noticeably worse, specifically in the late afternoon or evening hours.
Any idea why that happens?
The exact cause isn't fully known, but it's often linked to things like end-of-day fatigue, shadows growing longer, which might increase anxiety or cause misperceptions, or maybe a change in caregiver staff disrupting their routine.
So how do you manage sundowning? That's likely what the test questions focus on.
Right. Management involves things like maintaining calm, predictable routines, especially in the evening, avoiding overstimulation like loud TV or too many visitors late in the day, making sure the resident is physically comfortable, not hungry, not thirsty, not in pain, creating a soothing environment.
Okay. Another really complex high-miss term, paranoia.
Paranoia. This is defined as the person believing, without any basis in reality, that others are out to harm them, steal from them, or deceive them. And this belief feels absolutely real and terrifying to the resident experiencing it.
And here comes the classic test scenario.
You got it. If a resident with paranoia accuses you, the NA, of theft, maybe they insist you stole their glasses or their money.
What is the correct response?
Do not argue, do not get defensive, or try to reason with them about why you wouldn't steal. That just feeds into the delusion for them.
So what do?
You gently reassure the resident. Say something calm like, "I'm sorry you can't find your glasses, let me help you look." You help them check their belongings. Often the stolen item is just misplaced nearby. And then you report the accusation and what happened to the nurse immediately. Reassure, assist, report. Don't argue.
Okay. Reassure, assist, report.
Got it.
Lastly, in this cognitive section, obsessive-compulsive disorder, OCD.
OCD. This involves repeated uncontrollable thoughts, which are the obsessions, and then repeated ritualistic actions, which are the compulsions.
Like constant hand washing.
Exactly. Or maybe needing to check that the door is locked multiple times, or constant counting, or arranging objects in a very specific way.
And the NA's role.
Primarily, it's to respect and try to accommodate these rituals, as long as they aren't causing physical harm or completely preventing necessary care like bathing or eating. Patience and understanding are key. Don't interrupt the ritual unnecessarily.
Okay, so when you're dealing with confusion or dementia, communication has to become really specialized. We need to define two key techniques here. And these are often confused on the test because when you use them depends entirely on the resident's specific condition.
Right. The first one is reality orientation.
Reality orientation. This is that structured approach of reminding residents about the current reality, the date, the time, where they are, using clocks, calendars, verbal cues.
Exactly. And the purpose is to help them stay grounded, oriented, connected to the here and now.
So when is this technique useful?
It can be very helpful for residents experiencing acute confusion, maybe confusion from that UTI or a high fever, or recovering from anesthesia after surgery. For temporary confusion, gently reminding them, "It's Tuesday morning, Mr. Smith, and you're safe here at the facility," can be really beneficial.
But there's a big but, isn't there?
Huge but. When you're dealing with someone who has established progressive, irreversible dementia, especially in the moderate to later stages, reality orientation can actually be harmful.
Harmful.
Because you're forcing them to confront a reality that their damaged brain simply cannot process or accept. It causes intense fear, frustration, anxiety. It can often lead to what's called a catastrophic reaction, like sudden lashing out, screaming, or extreme distress. It's counterproductive and unkind.
So for irreversible dementia, we need a different approach.
Absolutely. And this is why validation is so incredibly critical, especially in dementia care. Validation is the heart of what's called validation therapy.
Okay, define validation for us.
Validation means accepting a resident's feelings and their personal reality as being true and important for them, even if the facts they're presenting are objectively wrong. You connect with and validate the underlying emotion, not the factual error.
Okay, Let's use that classic high-miss scenario again to make this really clear. Resident with dementia thinks it's 1950, they're crying, asking for their mother.
Right. The wrong response, the reality orientation response that causes distress, would be to say, "No, Mrs. Davis, it's 2024. Your mother passed away many years ago." Factually correct, perhaps, but emotionally devastating and useless for her.
So the correct validation response is,
You engage with the emotion. You do not argue about the year or the mother's status. Instead, you validate the feeling of missing her mother, or maybe feeling worried or lost.
so you might,
You might say something gentle like, "Oh, it sounds like you really miss your mother right now. Tell me about her. Was she a good cook?" Or, "You sound worried. Are you feeling unsafe?" You step into their reality for a moment to address their emotional need for comfort and security.
that makes so much sense. And this practice leads directly to validation therapy.
Exactly. Validation therapy is the broader technique of deliberately going along with or entering into a confused resident's reality as a strategy to reduce their stress and distress. It puts the person and their feelings first, not the objective facts.
So if a resident calls you by the wrong name, maybe calls you mom, or thinks you're their old friend, Nurse Jones,
You respond kindly, calmly, match their emotional tone if you can, but you don't need to aggressively correct them, "I'm not your mom." That just causes upset.
so focus on the underlying need.
Always. What are they really seeking in that moment? Probably connection, comfort, reassurance, safety. Address that need, rather than getting hung up on factual accuracy, which their brain simply cannot process anymore. Okay, we're wrapping up now with terms related to societal bias, and then shifting to the most sensitive area of care, end-of-life planning and care. Let's start with stereotypes.
Stereotypes. Those are those false, usually rigid, oversimplified ideas or beliefs we hold about entire groups of people.
Right. And in our context, related to aging, this includes thinking things like all old people are forgetful or helpless or constantly sick or maybe unable or unwilling to learn new things like technology.
And these negative assumptions, they're basically rooted in ageism.
Exactly. Ageism is that prejudice, discrimination, or hostility directed against older people simply because they are old. The test absolutely requires you to reject these biases.
So you have to constantly remind yourself.
That older adults are incredibly diverse. They have vastly different capabilities, skills, interests, personalities, just like any other age group.
And aging itself.
Aging is a normal, natural part of life. It is not a disease. And older adults do not inherently need to be dependent or treated like children.
So your role as an NA is actually to fight against that.
Absolutely. Foster their autonomy. Encourage them to manage their own lives and make their own choices for as long as they possibly can. Resist that cultural urge to just take over and treat them like fragile objects. Promote independence always.
Okay, important perspective. Now, switching focus completely. Terminal illness.
Terminal illness. This is defined as a disease or condition that medical professionals have determined will eventually cause death. The timeline might be uncertain, could be months, could be years, but recovery isn't expected.
And when you're caring for residents facing this, you need to be aware of the emotional journey they and their families are often on.
Yes. We often refer to the framework developed by Dr. Elizabeth Kubler-Ross, her 5 stages of dying or grief.
Which are?
Denial, anger, bargaining, depression, and acceptance. Now, it's really important to note for the exam, residents may not go through these stages in a neat, linear order. Some might skip stages, some might go back and forth. It's not a checklist.
Okay, so denial might look like what?
Maybe the resident keeps seeking second, third, fourth medical opinions, insisting the doctors must be wrong about the diagnosis or prognosis.
Anger.
Anger is often directed outward. They might lash out at staff, at family members, even at God or the universe, asking, "Why me?"
Bargain.
Bargaining often involves trying to make deals, usually with a higher power. If I just live long enough to see my grandchild graduate, or if I take all my medicine perfectly, can I make it to Christmas?
Depression.
Depression involves withdrawal, profound sadness, maybe silence, crying, mourning the losses already happening and those yet to come.
And finally, acceptance.
Acceptance isn't necessarily happiness, but more of a peaceful resolution, maybe tying up loose ends, saying goodbyes, a sense of calm readiness.
And throughout all these potential stages, the NA's role remains consistent.
Absolutely consistent. Provide compassionate care with utmost dignity. Respect all the residents' rights, including their right to refuse treatment, their right to have visitors or be alone, and their right to privacy. Listen more than you talk.
Okay, now we need to distinguish between 2 specific types of comfort-focused care.
Right. Hospice care and palliative care. They're related but distinct.
Let's start with hospice.
Hospice care is specifically for people who have received a medical prognosis of having 6 months or less to live if the disease runs its natural course. The entire focus of hospice shifts away from cure or recovery
To what?
to comfort symptom management like pain, nausea, anxiety, and preserving dignity. It's about quality of remaining life, not quantity.
Okay. And palliative care, how is that different?
Palliative care is also comfort care, focused on relieving symptoms and stress of a serious illness. But crucially, palliative care can be provided alongside active curative treatment.
So you could receive palliative care while still getting chemotherapy for cancer.
Exactly. Or while getting treatment for advanced heart failure, or AIDS, or COPD. Palliative care aims to improve quality of life at any stage of a serious illness, whether it's terminal or not.
But the goals of both hospice and palliative care are fundamentally similar.
Very similar. Maximum comfort. Meeting all those needs, physical, emotional, social, spiritual, ensuring the highest possible quality of life for whatever time remains.
Okay. And finally, the term post-mortem care.
Post-mortem care. This is the physical care of the body immediately after death has occurred. This is often an NA responsibility, performed under the direction and supervision of the nurse.
What does it involve?
It typically involves gently washing and cleaning the body as needed, closing the eyes, placing clean drainage pads under the buttocks area as relaxation after death can cause elimination, positioning the body naturally, usually flat with arms at the sides or across the abdomen, according to the facility's policy.
And you mentioned something about rigor mortis.
Yes, a practical tip. Rigor mortis is the natural stiffening of the body's muscles that starts within a few hours after death. It can make the limbs difficult to move, so you need to handle the body gently and respectfully throughout the process. Don't force anything.
Okay. And what is the absolute non-negotiable point here for the test related to scope of practice?
The absolute critical point. CNAs should never, ever remove tubes or other medical equipment attached to the body.
Like 5E lines, catheters, oxygen tubing, feeding tubes.
Any of it. Leave it all in place. Only the nurse or other specifically authorized personnel, like from the funeral home or medical examiner's office, can remove that equipment. Your job is simply to prepare the body respectfully and with dignity for viewing by the family or for transfer. #tag outro. Really mastering the terms in this chapter, chapter 3, marks a pretty pivotal shift in your development as a caregiver. It's about moving beyond just the mechanics of ADLs.
Right, beyond just the tasks.
Exactly. It's about moving towards providing truly holistic, genuinely person-centered care. Care that respects the independence, the culture, the history, and the dignity of every single resident, right from when they arrive through to the very end of their life.
And getting that deep understanding, that's really what's going to help you nail those scenario questions and secure your certification. Okay, so as a final provocative thought for you to kind of chew on before your exam, we talked about advanced directives.
Things like the living will, the durable power of attorney for healthcare, and especially the DNR, the do not resuscitate order.
And you understand absolutely that these are legal documents. They must be honored by everyone, including you as an NA.
Right. No question there.
But ask yourself this. If a resident has a valid DNR order, meaning extraordinary measures like CPR should not be performed if their heart stops or they stop breathing, why is it still absolutely vital that you, the NA, continue to closely monitor and report their vital signs and their overall condition? Why keep checking if you're not going to intervene aggressively?
It's a really good question to ponder. Why bother monitoring if the plan is not resuscitation?
Think about that. Even when aggressive treatment stops, compassionate care never ever ceases. The answer lies right back in that fundamental goal of person-centered, holistic care.
Which is always, always ensuring the resident's comfort and dignity above all else. Those vital signs, your observations about their breathing, their skin color, their level of consciousness, their restlessness.
That's the only way the care team knows if the resident might be experiencing unmanaged pain or worsening anxiety or shortness of breath that can be eased with medication or positioning.
Exactly. Comfort measures like pain medication or oxygen for comfort will still be used aggressively, even with a DNR. The monitoring continues relentlessly because the pursuit of comfort, the honoring of dignity, must never stop.
A really profound point to reflect on as you finish your studies. Good luck with your final preparation for the Headmaster exam, and be sure to tune in next time for part 4 of our deep dive series.
Welcome to part 4 of our Key Terms podcast series for the Headmaster Test Prep.
Yeah, there are 10 parts in total, one for each chapter.
So stick with us, and hopefully we can help you ace your exam. Today we're doing a deep dive, really focusing only on the essential vocabulary for that Headmaster test.
Right.
We're not just skimming, we're trying to break down those sometimes tricky medical terms.
The ones that show up a lot in those high-miss questions or the scenario problems.
Exactly.
And, if you're getting ready for that written exam, just memorizing definitions isn't really enough, is it?
No, not at all.
You have to get these terms in context. Like, what do you do? What's your mandatory action as an NA when you see these conditions in a resident?
That's the goal today. Turn these keywords into, immediate action plans for you.
Yeah, let's do it.
Okay, let's dive in. We'll start with the systems that, hold us together and protect us.
Good place to start.
So, Section 1, the integumentary and musculoskeletal systems. First up, the basics, anatomy. Simply put, it's the study of the body's structures, how all the pieces fit, and importantly, how they work together.
Right, form and function.
Then we have the integumentary system. That's our largest organ system, really.
It is skin, hair, nails.
Yeah.
It's the body's natural protective covering, like armor.
And if you think of it like armor, then skin integrity becomes, super important.
Absolutely critical. Skin integrity just means keeping that armor, that skin, healthy and whole. No breaks, no sores.
Because if that integrity is compromised...
Infection. That's the big danger. And that's why your observation skills are so crucial here.
Which brings us right to the test focus. Skin observation. This isn't, a quick check-off item. It's something you need to do routinely, almost obsessively, looking for changes.
What kind of changes?
Like redness, any bruises, or maybe skin that's really, really dry.
Okay.
And think about a classic test scenario, a high-miss one.
Right.
When you're doing perineal care, maybe helping with a bath, you have got to specifically check those bony spots.
Like the tailbone, elbows.
Exactly. Tailbone, elbows, shoulder blades, and especially the heels.
Heels are notorious.
You're looking for any redness there, whether it blanches or not. That focus check, doing it every time, it's a mandatory NA task. It's your earliest warning sign.
And that observation, that warning sign, leads us straight into another massive high-miss topic for the test. Pressure injuries.
Right. Often called a pressure ulcer.
Or deocubitus ulcer.
Yeah.
They all mean the same thing. It's basically a bed sore.
Caused by pressure.
Exactly. Prolonged pressure that cuts off the blood flow to that area.
Okay, so prevention is obviously key. We always hear about turning residents every 2 hours. Why is that timing, that 2-hour mark, so critical? What's actually happening in the skin?
Well, you're preventing something called ischemia, which we'll touch on more later, but basically, you're stopping the blood flow from being cut off for too long.
Okay.
When pressure squeezes those tiny blood vessels, the capillaries, shut for, more than about 2 hours, the tissue doesn't get oxygen. It doesn't get nutrient.
And it starts to die.
It starts to break down, exactly. And the test often zeroes in on that earliest sign you have to report. That's stage 1.
Which looks like?
Just simple red skin. But the key is, it doesn't go away when you take the pressure off.
Yeah.
If you catch it then, report that stage 1 redness, the damage is often reversible.
But if that window is missed...
Then the injury can progress. It goes into the deeper tissue.
Which means?
It means it's gone beyond just the top layer of skin. It's now involving the muscles and fat underneath. Much more serious. Harder to heal, needs complex care.
Got it. And while we're talking skin, what about just plain dry skin?
Oh yeah, very common, especially in older adults. Their skin naturally produces less oil.
And dry skin can't crack.
Easily. And those tiny cracks, they're breaks in skin integrity too. Little openings for infection.
So the NA's role is pretty straightforward.
Yes, simple but important. Apply lotions as ordered. Keep the skin moisturized, keep it supple, prevent those cracks.
Okay. So we've covered the outer protection. Now let's talk about the framework inside. What allows movement, or sometimes prevents it? The musculoskeletal system.
Right. Bones, muscles, joints. Support and movement.
But when a resident can't move, when they're immobile, that's when we see some serious problems. The test definitely hits on these dangers.
2 big ones to know: atrophy and contracture.
Let's take atrophy first. That's when muscles shrink.
Shrink and weaken, yeah. Simply from not being used. It's bad, obviously, but often with therapy you can regain some strength.
Okay, but then there's contracture. You said that one's scarier.
It is. It's a really high-miss term because of the implications. A contracture is a permanent shortening. Permanent hardening, shortening of the muscles or the tendons or other tissues, usually around a joint.
So the joint gets kind of stuck.
Exactly. It can get locked in a bent position, sometimes forever. It severely limits function and can be very painful.
Okay, so here's a little quiz moment for our
Right.
listeners thinking about the test. What's the key difference between atrophy and contracture? And what's the main care technique, the mandatory one, to prevent both?
Okay, the difference. Permanence. Atrophy is weakening, maybe reversible. Contracture is permanent fixation, permanent shortening.
And the prevention.
Mandatory prevention for both is range of motion exercises, ROM,
Why does ROM help so much?
because you're moving the joint through its normal range. It keeps the joint lubricated, and it keeps the tendons stretched and flexible.
And tendons are.
Those strong, cord-like tissues that connect muscles to bones, ROM keeps them from shortening and tightening up.
Gotcha. Okay, moving to common conditions affecting this system. Arthritis.
Very common. It's inflammation in the joints, causes pain, stiffness, makes movement difficult.
So NA care focuses on.
Assisting with gentle movement, but only as much as the resident can tolerate. Never force it. And comfort measures, like applying warm packs if the care plan says so, easing that discomfort.
Then there's osteoporosis.
Right. This is where bones become porous, brittle. They break really easily. Much more common in older women, especially after menopause.
And you said this is another huge high miss area. Why? What's the absolute core responsibility for an NA with an osteoporotic resident?
One phrase: fall prevention.
Okay.
You have to treat these residents almost like they're made of glass. A simple bump, a turn in bed, a small slip, it can cause a fracture, especially hip fractures.
So things like gait belts.
Absolutely. Gait belts, keeping walkways totally clear, answering call lights immediately so they don't try to get up alone, non-negotiable safety measures.
And speaking of fractures, let's talk about hip fractures specifically, or after someone gets a hip prosthesis, an artificial joint. Post-op care here is prime territory for test questions because there are several rules to follow.
Definitely. Lots of steps involved. Let's break down those key rules. There are about 4 main ones you absolutely need to know.
Okay, rule number 1.
Keep everything the resident needs within easy reach. Call light, phone, remote, water. Prevents them from twisting or bending too much.
Makes sense. Rule 2, dressing.
Yes. Always, always. Dress the affected side first. The weaker side goes into the clothes first. And when undressing, you take it off the stronger side first.
Affected side first for dressing. Got it. Rule 3.
This one's critical. No crossing the legs. Absolutely forbidden. It can pop that new hip right out of the socket.
Wow. Okay, no leg crossing. And rule 4.
The hip angle. You cannot let the hip bend or flex more than 90 degrees.
So no leaning way forward.
Right. No leaning forward when sitting. No sitting in low, soft chairs. It puts too much strain on the joint. Risks dislocation.
And what about transfers, like getting up from a chair?
Crucial point. Always have the resident lead with their stronger side. Stand, pivot on the strong leg. You support the weaker side, but the strong side does the work.
Okay, that's a really clear breakdown. Those 4 rules: reach, dressing, no crossing, 90 degrees, plus leading with the strong side. Very testable.
Very.
All right, let's shift gears now. Moving from the framework to the command center, section 2, the nervous system.
Okay, the control hub. The central nervous system, or CNS. That's basically the brain and the spinal cord. Controls thinking, feeling, movement, pretty much everything.
And when this system gets damaged, the effects can be devastating. A common acute event is a stroke.
Right. Often called a CVA, which stands for cerebrovascular accident,
Then that means
brain damage. It happens because a blood vessel in the brain gets either blocked, that's an ischemic stroke, or it bursts, which is a hemorrhagic stroke.
either way, blood flow stops.
Exactly. Brain cells don't get oxygen, and they die. This causes loss of function, typically on the side of the body, opposite to where the brain damage occurred.
And that loss of function has a name: paralysis.
Right, loss of muscle movement. And the test will likely want you to know 2 specific types. Hemiplegia, that's paralysis on one side of the body, very common after a stroke.
Okay, one side. And the other type.
Quadriplegia, that's paralysis affecting all 4 limbs, arms, and legs. Usually results from a severe injury high up on the spinal cord. Got it. Hemi is half, quad is 4. Now that hemiplegia scenario comes up a lot in questions about transfers, right?
Absolutely. Because one side is weak or paralyzed, you have to make sure the resident uses their stronger side to lead the movement.
Why is leading with the strong side so important?
Stability. Confidence. If they try to put weight on the weak or paralyzed leg first, it could just buckle. Instant fall risk.
So your job as the NA.
Your job is to stand on and support their weaker side, guard it, protect it, but guide them to use the strong side to push up, pivot, and sit down safely.
Okay, makes sense. Now, strokes often cause communication problems too. Let's talk about aphasia.
Right. Aphasia means difficulty with language, either trouble speaking words or trouble understanding words, or sometimes both.
And this is a big high-miss area testing communication skills.
Huge, because it requires specific techniques. The absolute key here is patience. Don't rush them.
So practically, what should you do? Use very clear, simple language. Ask simple yes-no questions whenever possible. Use gestures, or even better, pictures or communication boards if they're available.
And give them time.
Lots of time. It might take them several seconds, even minutes, to process what you said and try to form a response. Never interrupt or finish their sentences for them. That's disrespectful and just increases their frustration.
Good advice. Okay, moving on to uncontrolled electrical activity in the brain. Epilepsy.
Epilepsy is the condition, the neurological disorder where someone has repeated seizures.
And a seizure itself is.
That sudden, temporary burst of abnormal electrical firing in the brain. It can look like convulsions through the uncontrolled shaking, or sometimes it's much quieter, like a blank stare, an absent seizure.
Okay, the test loves seizure scenarios. What are the absolute must-do actions for an NA if a resident starts having a convulsive seizure? 3 main things.
3 critical steps, yes.
Yeah.
1, protect the head. Ease them to the floor if possible. Put something soft like a pillow or fold a towel under their head. Move furniture away.
Okay, protect the head. 2.
Time the duration. Note exactly when it started and when it stopped. This is crucial information for the medical team.
Time it. And 3.
Report the event immediately to the nurse. As soon as the active seizure stops, tell them how long it lasted and what you observed, what parts of the body were moving, etc.
And just as important, what not to do.
Absolutely. Never, ever try to restrain the person's movements, and never, ever put anything in their mouth. That's an old myth and very dangerous.
Got it. Protect, time, report. Don't restrain, don't put anything in the mouth.
Okay, what about just feeling unsteady? Dizziness.
Dizziness, that feeling of spinning or being off balance. Seems minor, maybe, but it's a huge fall risk.
What usually causes it?
Could be inner ear problems, could be low blood pressure, especially when standing up quickly, could be medication side effects, whatever the cause. If a resident says they feel dizzy, you report it immediately.
Okay, now let's touch on some nervous system disorders that get worse over time, progressive disorders. Right, first is multiple sclerosis, or MS. This is an autoimmune disease. The body's own immune system attacks the protective covering around the nerves.
And that causes
A whole range of symptoms that can come and go, or steadily worsen. Things like muscle weakness, problems with balance and coordination, numbness, tingling, extreme fatigue. It's defined as progressive because the underlying damage tends to accumulate over time.
Okay. Another major progressive one is Parkinson's disease.
Yes. Parkinson's happens when certain brain cells that produce a chemical called dopamine start to die off. Dopamine is crucial for smooth, coordinated muscle movement.
So the symptoms are related to movement problems.
Primarily, yes. You see muscle stiffness or rigidity, slowness of movement, often a stooped posture, and that characteristic shuffling walk, which we call an altered gait.
And the tremor.
Yes, the resting tremor often starts in one hand, that classic pill rolling motion, like they're rolling a pill between their thumb and forefinger. It's most noticeable when the hand is at rest.
Now, what's the high-miss scenario for Parkinson's on the test? What NA action is critical?
It often relates to feeding. Because of that tremor, especially if it's severe, it can become very difficult, even impossible, for the resident to get food from the plate to their mouth without spilling.
So you need to
recognize when assistance is needed. Always encourage them to do as much as possible for themselves, promote independence. But if the shaking makes eating unsafe or means they aren't getting enough nutrition, then assisting them with feeding becomes a necessary part of your care.
Okay, important distinction. Encourage first, assist when necessary.
Exactly.
All right, let's briefly cover the senses vision and hearing. Lots of residents experience vision change.
Very common. Blurriness, maybe difficulty seeing in dim light, sometimes partial vision loss, often due to aging or conditions like cataracts or glaucoma.
The test often focuses on care for someone with significant vision loss or even complete blindness. What's the absolute golden rule here? High miss potential.
Respect and safety. You must always announce yourself when you enter their room. Don't just appear.
Okay, announce entry.
And then you must describe what you are going to do before you do it. For example, okay, Mrs. Jones, I'm going to help you sit up now. Or, I'm placing your water glass on the table to your right.
So they know what to expect.
Precisely. It builds trust and prevents startling them. And a simple, practical task, make sure their eyeglasses, if they wear them, are clean and always within their reach.
Good tips. What about hearing? Residents who are hearing impaired?
Meaning they have some level of hearing loss. Many use a hearing aid,
Which is?
a small electronic device worn in or behind the ear that amplifies sound, makes it louder.
What are the NA's responsibilities regarding hearing aids? This comes up, right?
It does. You need to know how to handle them carefully. They need to be cleaned daily, usually just wiped gently with a soft, dry cloth, but follow the specific facility policy.
Okay, clean daily. What else?
Check the batteries regularly, make sure they're working, and when you're talking to someone who's hearing impaired, face them directly. Stand where the light is on your face, not behind you.
So they can see your lips.
Exactly. Lip reading helps many people. Speak clearly, speak slowly, use a normal tone of voice. Don't shout. Shouting actually distorts the sound and doesn't help.
Face them, speak clearly, don't shout. Got it. All right, moving on. Let's talk about the body's engine and its air supply. Section 3, the circulatory and respiratory systems. Starting with the circulatory system.
Also called the cardiovascular system. Cardio for heart, vascular for vessels.
And its job is circulation, right? Moving blood around.
Yep. The heart pumps blood through the vessels, arteries, veins, capillaries, carrying oxygen and vital nutrients to all the body tissues and carrying waste products away.
Okay, when we assess this system, we often measure things like blood pressure.
Right. That's the force of the blood pushing against the walls of the arteries.
It has two numbers.
Two numbers, systolic over diastolic. Systolic is the pressure when the heart contracts, pushes blood out. Diastolic is the pressure when the heart rests between beats.
Okay, and we also measure the pulse.
Which is the rhythmic expansion of an artery that you can feel each time the heart beats. Usually felt at the wrist, the radial pulse.
Now, here's a really important detail for the test regarding pulse measurement you have to count for.
A full 60 seconds. 1 full minute. No shortcuts like counting for 15 seconds and multiplying by 4.
Why is a full minute absolutely mandatory?
Because you're not just counting the rate, the number of beats, you're also assessing the rhythm. Is it regular? Is it irregular?
Oh, all right.
If the resident has an irregular heartbeat, maybe skip beats or extra beats, you might miss that completely if you only count for 15 or 30 seconds.
And if the rhythm is irregular?
You must report it immediately to the nurse. An irregular rhythm can be a sign of a serious underlying problem, even if the rate itself seems normal.
Got it. Full minute, check rhythm, report irregularity. Sometimes the nurse might ask for an apical pulse.
Yes, that means listening directly over the apex, the bottom tip of the heart using a stethoscope, gives a very accurate count.
And if the heart rate is too fast, say over 100 beats per minute.
The medical term for that is tachycardia. Tachy means fast. Cardia refers to the heart.
Okay, let's talk about common circulatory problems. Hypertension or HTN?
High blood pressure. Extremely common and very damaging over time if not controlled.
Why is it so damaging?
It makes the heart work way harder than it should. Over years, this can weaken the heart muscle. It also damages the walls of the blood vessels, making them stiff and narrow, increasing the risk of heart attack, stroke, kidney failure.
Wow. Okay. What about chest pain? Angina.
Angina is chest pain or discomfort that happens when the heart muscle isn't getting enough oxygen-rich blood, usually triggered by exertion or stress, and typically relieved by rest or medication like nitroglycerin. It's a warning sign of underlying heart disease.
Okay. A really complex disorder we often see is congestive heart failure, or CHF.
Yes, very common in long-term care.
Oh.
CHF means the heart muscle has become weak and can't pump blood effectively anymore. It's failing as a pump.
So the blood backs up.
Exactly. Blood backs up in the system. Fluid then leaks out of the blood vessels into the surrounding tissues. This causes swelling, which is called edema. You usually see it in the feet, ankles, legs first.
And does that fluid backup affect the lungs too?
It does. Fluid can back up into the lungs, causing congestion, shortness of breath, difficulty breathing. That's why CHF residents often have breathing problems and might be on fluid restrictions.
So how does that impact the NA's daily work? What are your key tasks for a CHF resident?
Oh, hugely important. You'll likely be monitoring their intake and output INO, measuring everything they drink and all the urine they put out, very precisely.
Right.
To track their fluid balance. Are they retaining fluid? Are the diuretics working? You might also have to weigh them daily, measure their legs to track edema, maybe apply special stockings called anti-embolic stockings, all to help manage that fluid overload.
Okay. What if the poor circulation is mainly in the legs and feet?
That's often called peripheral vascular disease, or PVD. Peripheral meaning away from the center. Poor blood flow in the arteries of the limbs.
And that causes pain.
Yes. Typically pain or cramping in the legs, especially when walking. It happens because the muscles aren't getting enough oxygen due to the poor blood flow. That lack of blood flow causing pain is called ischemia.
Ischemia. Got it. A danger with PVD is a blood clot, right? A thrombus.
Yes, a thrombus is a blood clot that forms inside a blood vessel. If it blocks a major artery, it's an emergency. If it breaks loose and travels, it's called an embolus, also very dangerous.
Okay. And less dangerous, but still common, are varicose veins.
Right. Those swollen, twisted-looking veins you often see in people's legs happens when the valves inside the veins weaken, letting blood pool backwards instead of flowing efficiently back to the heart.
All right. Let's connect circulation to breathing. The respiratory system.
The lungs and airways, their job is respiration, or breathing.
Which is basically
taking in oxygen, getting rid of carbon dioxide. Simple concept, vital function.
Key parts involved are the diaphragm,
The big muscle underneath the lungs that does most of the work of breathing.
the trachea,
The windpipe, the main airway down to the lungs.
and the pleura.
The thin double-layered membrane that surrounds the lungs and lines the chest cavity. Helps them glide smoothly during breathing.
Okay. Now, just like measuring the pulse had a special rule, measuring respirations has a critical high-miss rule, too.
It does. You count the number of breaths. One inhale plus one exhale counts as one breath for a full 60 seconds. But you have to do it without the resident knowing you're counting their breathing.
That sounds tricky. How do you manage that? Why is it important?
It's important because if people know you're watching them breathe, they almost always subconsciously change their breathing pattern. They might breathe faster or slower or hold their breath. Makes your count inaccurate.
So how do you do it sneakily?
The easiest way is right after you finish counting their pulse. Keep your fingers on their wrist as if you're still feeling the pulse, but shift your focus and watch their chest rise and fall. Count the breaths for the full minute then. They usually just think you're taking a long time with the pulse.
Clever trick. Count respirations right after pulse while still holding the wrist.
Works like a charm.
Okay, let's talk respiratory disorders. Chronic obstructive pulmonary disease, COPD.
COPD is an umbrella term for chronic lung diseases that block airflow and make breathing difficult. The most common ones are chronic bronchitis and emphysema.
Emphysema specifically damages.
The tiny air sacs in the lungs, the alveoli, they lose their elasticity, get damaged, makes it very hard to fully exhale. Air gets trapped in the lungs.
So someone with COPD or emphysema might often feel short of breath. The term is dyspnea.
Yes, dyspnea means difficulty breathing or shortness of breath. It's a hallmark symptom.
If your resident is experiencing dyspnea, what's the immediate action? Highly testable.
Position them upright immediately. The best position is often the orthopneic position.
Which is?
Sitting up straight, maybe leaning slightly forward over a bedside table with pillows for support. This uses gravity to help the lungs expand fully. So position them upright, stay with them, and report the dyspnea to the nurse right away.
Upright position, report immediately. Got it. Now, oxygen use and safety. Huge topic.
Absolutely critical. Oxygen is a medication, even though it's a gas. It's usually delivered through a nasal cannula, that's the plastic tubing, with prongs that sit just inside the nostrils or sometimes a mask. There's always tubing involved connecting to the oxygen source.
Because it's a medication and supports combustion, safety is paramount. What are the two absolute life-or-death safety rules for oxygen use? High miss, for sure.
Rule number 1, oxygen makes things burn hotter and faster. So absolutely no smoking or open flames anywhere near where oxygen is in use or stored. No candles, no lighters, no matches. Check for no smoking signs.
No smoking. Rule number 2.
The tubing. Oxygen tubing lying across the floor is a massive trip hazard. You are responsible for making sure the tubing is safely managed, maybe coiled on the bed or secured along the wall, tucked out of the way. Preventing trips and falls around oxygen equipment is key.
No smoking, manage the tubing. Okay, what about mucus, secretions?
Secretions or phlegm or mucus, it's the stuff people cough up from their lungs or airways.
Yeah.
We need to encourage residents, especially those with respiratory issues, to cough effectively to clear those secretions out. Prevents pneumonia.
Or sometimes you need to collect that stuff, a sputum specimen.
Yes. Sputum is the mucus coughed up from deep in the lungs, not just the saliva. We collect a sample in a sterile cup, usually first thing in the morning, to send to the lab. They test it to see if there's an infection, like pneumonia or tuberculosis.
Okay, good overview of respiratory. Let's move down to waste management. Section 4, the urinary and gastrointestinal systems. First, the urinary system.
Kidneys, bladder, ureters, urethra. Makes urine, stores it, gets rid of it. Filters waste from the blood.
And again, NA observation is key here. What should you be looking for in the urine?
Changes. Is it dark? Is it cloudy? Does it have a strong foul odor? Is there blood in it? Any of those changes need to be reported. Also, how much are they voiding? Too little? Too much?
Okay. The most common problem in this system.
Probably a urinary tract infection, or UTI, an infection anywhere in the urinary tract, but usually the bladder or kidneys.
Causes pain when urinating. The term is dysuria.
Yes, dysuria, painful or burning urination, is a classic symptom. Also urgency, frequency. But UTIs are a major high-miss area on the test, especially regarding older adults.
Why is that? How do they present differently?
Because in the elderly, those classic symptoms, the pain, the burning, maybe even fever, might be completely absent.
So what is the sign, the critical one an NA must catch?
Confusion, a sudden change in mental status.
Yeah.
New onset confusion, increased agitation, unusual lethargy or sleepiness. In an older resident, especially one with dementia, that might be the only sign of a UTI.
Wow. So any sudden confusion, report it immediately as a possible UTI.
Absolutely. Report any change in mental status, period. But keep UTI high on the list of possibilities.
In prevention, key tips.
Encourage fluids, lots of water, unless they're on restriction. And proper hygiene, always wipe front to back after toileting, especially for female residents. Reducing the risk of bacteria getting into the urethra.
Okay. What about edema again? We mentioned it with CHF.
Right. Edema is swelling caused by excess fluid trapped in the body's tissues. Can be caused by heart failure, kidney problems, liver disease. If you see new or worsening swelling, especially in the legs or feet, report it. Your tasks might include elevating the legs, applying special stockings, or measuring the leg circumference.
And the general term for getting rid of waste, elimination.
Yes, elimination refers to the body getting rid of waste products, both urine and stool. Part of your job is accurately observing and recording elimination frequency, amount, characteristics. Input and output includes recording elimination.
Okay. Let's talk catheters and incontinence. Catheter care.
When a resident has an indwelling urinary catheter, a tube inserted into the bladder to drain urine continuously, you need to provide regular care to keep the insertion site clean and prevent infection. This procedure is very testable.
So let's nail down the technique. Cleaning direction.
Always clean away from the body. Start at the opening where the catheter enters the body and clean downwards along the catheter tube about 4 inches or so. Use a clean part of the washcloth for each stroke.
Away from the meatus, down the tube, and the drainage bag. The absolute rule.
The bag must always be kept below the level of the bladder. Always, always, always.
Why is that so critical?
To prevent backflow. If the bag gets higher than the bladder, urine can flow backwards up the tube and into the bladder, carrying bacteria with it. Huge risk for serious infection. Keep it low, off the floor.
Got it. Keep the bag below the bladder. What's a suprapubic catheter?
That's a type of catheter that's inserted surgically directly through the abdominal wall into the bladder, bypassing the urethra altogether. Care principles are similar. Keep the site clean, ensure proper drainage, bag below bladder.
Okay. Now, incontinence.
The inability to control the release of urine or stool. Very common in long-term care, but important to remember, it is not a normal part of aging. There's usually an underlying cause.
And incontinence is a major risk factor for him.
Skin breakdown, pressure ulcers. The moisture from urine and the enzymes in stool are very irritating and damaging to the skin.
So the NA's role is critical for prevention.
Absolutely. You must check residents frequently, change wet or soiled briefs and pads immediately, provide good skin care after each episode. Promptness is key.
And sometimes we assist with retraining.
Yes, bladder training programs might be ordered. These involve scheduling toileting, encouraging fluids at certain times, helping the resident regain some control. It requires patience and consistency. Also, it's important to be reassuring and maintain dignity. There are different types. Stress, urge, and management is often possible.
Okay. Let's move to the other elimination system. Bowel function, digestion.
The whole process of breaking down food so the body can absorb nutrients.
And what keeps the food moving through the gut?
Peristalsis, those wave-like muscular contractions that push food along the digestive tract.
The end product, solid waste, is feces or stool, and gas is flatus.
Correct.
What happens if peristalsis slows down?
You get constipation. Stools become hard, dry, difficult to pass, and bowel movements are infrequent, often caused by immobility. Some medications like pain relievers, low fluid intake, or lack of fiber in the diet.
If constipation isn't managed, it can lead to something worse.
Yes, a fecal impaction. This is serious. It means a large mass of hard, dry stool gets stuck in the rectum and can't be passed.
How would an NA recognize a possible impaction? What are the signs to report urgently?
Two key things. One, the resident hasn't had a bowel movement for several days, despite maybe feeling the urge. Two, paradoxically, you might see continuous oozing of liquid stool
Liquid stool? Why?
because the body tries to push liquid around the blockage. So if you see someone who hasn't had a real BM in days, but is having small amounts of liquid stool leaking out, suspect an impaction and report it immediately.
And the nurse or doctor might order an enema.
Yes, an enema involves introducing fluid into the rectum to help soften and break up the stool to allow it to pass. Sometimes digital removal by a nurse or doctor is needed.
Yeah.
NAs do not perform digital removal.
Okay. Lastly in this section, ostomies. Some residents have a stoma.
Yes, a stoma is a surgically created opening, usually on the abdomen, that allows waste, either urine, urostomy, or stool, colostomy, ileostomy, to exit the body.
And the waste collects in an ostomy bag, so care involves.
Colostomy care or ostomy care in general. Two main focuses for the NA. First, meticulous skin care around the stoma. The skin there is very sensitive and can easily get irritated by the waste. Keep it clean and dry.
And second,
Emptying and sometimes changing the ostomy bag or appliance regularly whenever stool or urine collects. It's crucial to do this with sensitivity, ensuring privacy, and managing odor. Be matter-of-fact and supportive.
good points. Privacy and skincare are key. All right, final section. Section 5, the endocrine system and general conditions. Let's start with the endocrine system.
This is the system of glands like the thyroid, adrenals, pancreas that produce chemical messengers called hormones.
And hormones do what?
They travel through the bloodstream and regulate all sorts of body functions. Growth, metabolism, mood, sleep, blood sugar. It's the body's chemical control system.
Oh, okay. And understanding this system is vital because it leads us right to diabetes.
Exactly. Diabetes mellitus, a very common endocrine disorder. It's characterized by high levels of sugar or glucose in the blood.
Why does the sugar get high?
Either the pancreas isn't producing enough of the hormone insulin, or the body's cells aren't responding properly to the insulin that is produced. That's called insulin resistance.
And insulin's job is?
Insulin acts like a key. It unlocks the body's cells to let glucose, sugar, enter from the bloodstream, where it can be used for energy. Without enough working insulin, sugar stays stuck in the blood.
And that causes problems. There are classic warning signs of diabetes, right? Testable signs NAs need to recognize. 4 main ones.
Yeah, it's the classic polys. 1, excessive thirst polydipsia. 2, extreme hunger polyphagia. 3, frequent urination polyuria.
Thirst, hunger, urination. What's the 4th?
Slow healing of sores or infections. High blood sugar impairs the immune system and circulation, making it harder for the body to heal. If you notice these signs, report them.
Okay. And if someone's blood sugar is too high, the term is hyperglycemia.
Hyper meaning high, glyced referring to glucose, emia meaning in the blood. So too much sugar in the blood.
What's the high miss scenario for the NA here? What action do you take?
Well, NAs don't usually measure blood glucose, but you might observe a resident eating a lot of sweets against their dietary recommendations, or maybe they complain of symptoms.
Like feeling extra thirsty.
Exactly. Increased thirst, frequent urination, maybe feeling tired or blurry vision. If you observe the resident eating things they shouldn't, or if they report these symptoms, or if you see a high reading recorded by the nurse or the resident themselves, you need to report those signs of hyperglycemia immediately. It needs prompt attention.
Report signs promptly. Okay, let's cover some serious conditions in final terms. Cancer.
Cancer is basically uncontrolled abnormal cell growth. These cells can invade surrounding tissues.
Sometimes they form a lump, a tumor.
Right. A tumor is an abnormal mass of tissue. Tumors can be benign, non-cancerous, or malignant cancerous.
And if cancer spreads.
That process is called metastasis. Cancer cells break away from the original tumor, travel through the blood or lymph system, and start new tumors in other parts of the body.
A common treatment is chemotherapy.
Chemo. Powerful drugs used to kill cancer cells, but they often affect healthy, rapidly dividing cells too.
Which causes side effects.
Yes. Common ones are severe nausea, vomiting, hair loss, fatigue, increased risk of infection. It can be really tough on the resident.
So the NA's role during chemo is focused on support. High miss area.
Very much support, helping manage side effects, especially supporting their appetite, which is often poor due to nausea.
How can you help with appetite?
Offer small, frequent meals or snacks instead of large ones. Sometimes cold foods are better tolerated than hot ones. A weird tip that sometimes helps: use plastic utensils instead of metal, because chemo can cause a metallic taste.
Plastic utensils, interesting. What else should NAs report?
Report any new symptoms immediately. New lumps, unexplained pain, unusual bleeding or bruising, sores in the mouth, signs of infection like fever. Vigilant observation is key.
Okay. Let's hit a few general vocabulary terms that cross systems. Anemia.
Anemia means having a low number of red blood cells, or not enough hemoglobin in the red blood cells. Red blood cells carry oxygen.
So anemia causes.
Tiredness, weakness, pale skin, shortness of breath. Because the body isn't getting enough oxygen delivered.
And ischemia again. We mentioned it with PVD and angina.
Right. Ischemia is a lack of blood flow, and therefore oxygen, to a part of the body. Causes pain and tissue damage if it persists.
Okay. And terms for how long an illness lasts. Acute versus chronic versus progressive.
Right. Acute means it comes on suddenly and is usually short-term, like the flu or an acute injury.
Chronic means?
Long-lasting, often for life. Requires ongoing management, like diabetes, hypertension, arthritis, COPD.
That term progressive.
Means the condition generally gets worse over time, like Parkinson's, MS, Alzheimer's disease.
Got it. Let's quickly review two key NA support concepts. Immobility.
We've seen this everywhere. Not being able to move, it causes a cascade of problems. Muscle atrophy, contractures, blood clots, pressure ulcers, constipation, UTIs, pneumonia. Movement is crucial.
And impaired.
Means weakened or damaged, having reduced function, like impaired hearing, impaired vision, impaired mobility.
Okay, one last term. A specific professional. The podiatrist.
A foot doctor. Specializes in diagnosing and treating conditions of the feet and ankles.
This is a high-miss area because of what NIs should not do, right?
Exactly. NAs should never cut a resident's toenails, especially not if the resident has diabetes or PVD.
Why is that rule so strict?
Because residents with diabetes or poor circulation often have reduced sensation in their feet and heal very poorly. A tiny nick from nail clippers, which the resident might not even feel, can easily become infected, develop into a serious ulcer, and potentially lead to amputation. It's a huge safety risk.
So if you see long toenails or an ingrown nail or any sores or problems with the feet,
your job is to observe and report it to the nurse immediately. Foot care for these residents must be done by a licensed nurse or a podiatrist. NA role is observation and reporting only, no cutting.
Observe and report, do not cut. Crystal clear.
Good.
Well, that pretty much covers the essential vocabulary and the critical NA actions for Chapter 4. We hit the integumentary, musculoskeletal, nervous, circulatory, respiratory, urinary, gastrointestinal, and endocrine systems.
Yeah, quite a tour.
And we really tried to focus on those terms and scenarios that frequently trip people up on the Headmaster Test, the high-miss ones.
Definitely. Understanding the why behind the action is key.
So we want to leave you with a final thought to consider as you study.
Okay. We talked a lot today about immobility. We detailed how just not moving starts this, well, catastrophic chain reaction across nearly every single body system.
Muscles weaken and shorten.
Skin breaks down, blood clots form, lungs get congested, bowels slow down, risk of infection goes up.
It really affects everything.
It does. So if you only remember one overarching principle from this whole deep dive, maybe let it be this. Recognize that every time you help a resident turn or walk or even just shift their weight in a chair, you're not just helping their muscles.
You're doing more.
You're fundamentally helping to stabilize their entire internal environment. You're boosting circulation, preventing skin breakdown, keeping their lungs clearer, helping digestion, everything. So the question to ponder is, how might truly recognizing that total systemic connection change the way you think about and approach assisting with ADLs every single day?
That's a powerful way to frame it. Thinking about the whole person, the whole system with every action. Definitely something to reflect on. Thank you for joining us for this deep dive into Chapter 4, Key Terms. We hope it helps you prepare.
Good luck with your study.
And we'll see you next time as we continue our Key Terms test prep series.
Welcome to Part 5 of our Key Terms Deep Dive series for the Headmaster Test Prep. There are 10 parts total, one for each chapter. Stick with us to ace your exam. Today, we are undertaking a critical deep dive into Chapter 5, Cognitive Impairment and Dementia Care. If you're prepping for your state written exam, these aren't just, background concepts. These are the key vocabulary terms. They really help you understand the difference between, say, temporary confusion and those chronic progressive diseases like Alzheimer's. Essential stuff.
That's absolutely right. And the mission for you, the listener, isn't just about memorizing a definition list. It's really about mastering the application. How do you use this knowledge, these specific terms? They pop up all the time in those high-miss areas on the Headmaster exam, often in complex care scenarios. So we're going to pull these sometimes dry medical definitions right into the real world. We'll focus really hard on the critical care guidelines, the actions you actually take, because that's what gets tested again and again.
Exactly. We're kind of tracing a spectrum today, aren't we? We'll start with those acute conditions, like maybe simple confusion that hopefully can be reversed pretty quickly. And then we'll move into the chronic, really life-altering world of Alzheimer's disease. Every single term we cover is tied back to a practical action, something you need to know how to do as a nursing assistant, day in and day out. Let's unpack this really crucial chapter. Okay, let's start at the beginning. The term that really acts as the starting line for a lot of these cognitive changes. Confusion. Defined pretty simply, right? Just trouble thinking clearly or making sense of things. But as analysts know, when confusion hits suddenly, it's rarely simple.
Precisely. For the test, yeah, the definition's the easy part. The critical piece of knowledge, the thing you have to grasp, is that confusion can be temporary. And often, it signals an acute problem, an immediate physical crisis that needs attention now. You've got to be able to recognize those causes and report them immediately. Think body first, not just brain.
Okay, so that's huge for the test. What specific physical causes should trigger that immediate alarm bell for an NA? What should we be looking for?
Well, in long-term care, the big ones we see constantly are things like a urinary tract infection, a UTI, rapid drops in blood sugar, a sudden fever, or really any kind of infection setting in, and dehydration. Dehydration is a massive one. If you have a resident who seemed perfectly fine at breakfast, maybe a bit quiet, but then totally confused by lunchtime, it's almost certainly tied to one of these sudden shifts in their body. Your job is to report that change right away. Because treating the physical cause, like the UTI or the dehydration, often clears up the confusion.
That makes so much sense. It's connecting the dots between the infection, the fluid balance, and their mental state. Okay, let's get into the care guidelines then. If I walk into a room and my resident is clearly confused, what's the sequence? What actions do I need to take right then and there for their safety? This has to be testable.
Oh, absolutely. Safety is paramount. On the job and on the exam, rule number 1, non-negotiable. Never leave a confused resident alone, ever. Beyond that immediate safety step, the focus shifts to environmental control. You need to stay calm yourself, that's key. Then, reduce overstimulation. What does that mean? Turn off the noisy TV, maybe close the door to the hallway bustle. Just minimize the chaos. And when you speak, lower your tone of voice. Speak clearly. Speak slowly.
Right. And the reason for that low, clear tone isn't just about being nice, is it? It actually helps.
It absolutely does. You're actively working to reduce their anxiety, and it helps them process the information better when they're already struggling.
Okay.
And this actually leads perfectly into a little quiz tip, something that really highlights why consistency matters so much with confused residents.
Like,
why must you introduce yourself every single time you interact with them, even if you literally just saw them 5 minutes ago?
that's a great question. It really gets at the core of the impairment, doesn't it? The reason, and you definitely need this lockdown for the exam, is that confusion messes with their ability to register new information, seriously interferes with it. They can't make basic decisions easily, and they just don't remember recent interactions.
Yeah.
So they need that constant, gentle reorientation, that reassurance. And you always have to explain what you're going to do. Use simple words, one step at a time.
Perfect. Now let's shift from that internal state of confusion to how it might look on the outside. Let's talk about agitation. The definition here is feeling restless or upset. And it often shows up physically. You might see pacing back and forth, maybe wringing hands, sometimes even yelling.
Yeah, and when we see sudden, really severe agitation, our minds often jump to delirium, right? Which is that acute condition. Now, delirium itself might not be a specific key term to define on the test, but recognizing agitation as a major symptom is critical. Because delirium, that sudden confusion often kicked off by a bad infection or maybe a fluid imbalance, it often presents with intense restlessness, maybe anger, real trouble focusing. Agitation is a big part of that picture.
Exactly. Agitation is the behavior you can see. It's telling you something deeper is wrong. So let's say the test gives you a scenario. A resident is agitated. What's the immediate NA goal? What's your first move?
The primary thing, the first intervention, has got to be trying to figure out and remove the triggers. Is it too loud, too bright? Did the routine get disrupted? Whatever that stressor is, you need to try and eliminate it right away. Then you focus on trying to maintain their familiar routine as much as possible that brings security. And importantly, redirecting their attention. Gently guide them towards a simple, familiar activity, something focused.
Yes. Redirection over confrontation every time. That's a core principle. A great example, maybe the resident is pacing nervously by the exit door. Instead of saying, "Hey, stop pacing," which could escalate things, you might say something like, "Oh, Mrs. Jones, could you help me? Let's go fold these nice warm washcloths together," and gently guide her to that task.
That whole redirection strategy is super important for our next term, too. Disoriented.
Yeah.
This is when residents lose track. Maybe they don't know who they are or where they are or even what time it is. That loss of person, place, or time.
Oh, this is so common. You'll have a resident asking repeatedly, what day is it today? Or maybe insisting, I need to leave now. I have to pick up my kids from school, even though their kids are grown. That disorientation makes their current world feel really frightening, really unfamiliar.
So how do we intervene effectively? Is it just about telling them the facts? It's Tuesday, you're at the nursing home?
Well, you do start by gently providing the facts. You reorient them, use their name, state your name, mention the location, we're here at Sunnybrook Manor, and the date. But keep it simple. And importantly, if they seem distressed, like worried about those kids, you validate the feeling first before you hit them with the facts. You might say, I understand you're worried about your children. That sounds stressful. Then gently, today is Tuesday and we're here at Sunnybrook. And then crucially, follow up with clear, simple explanations about what's happening next. I'm going to help you brush your teeth now. That predictability helps counter the disorientation.
Okay, that makes sense. Validate the feeling, gently state reality, explain the next step.
Got it.
Let's connect physical status back to cognitive risk again with our last term in this sort of acute section. Drowsy. Seems simple, just means overly sleepy, lethargic, maybe hard to wake up.
Right. But drowsy is one of those deceptively simple words that can signal a really big problem. NAs must treat sudden, unusual drowsiness as a high-priority observation. Why? Because severe drowsiness, especially if it's a change from their normal alertness level, is a huge red flag. We're not just talking about needing a nap, we're talking about something potentially critical. It could indicate hypoxia, not enough oxygen. Or maybe a sudden drop in blood pressure, very low blood sugar. Or, and this is a big one, an adverse reaction to a medication.
Ah, okay, I see the test angle here. If a question describes a resident who's usually alert and oriented, maybe after lunch, but suddenly today they're slumped over, difficult to wake up. The correct NA action is always going to be immediate reporting to the nurse, isn't it?
Absolutely, 100%. That observation skill is exactly what's being tested. You're looking for that change from their baseline. If they're usually chatting after lunch and now they're barely responding to you calling their name, that signals a potential crisis. It needs immediate medical assessment. The faster the nurse knows about that significant drowsiness, the sooner they can check vital signs, maybe check blood sugar, and potentially prevent something serious like a fall or worse.
All right, now we're making a pretty significant shift. We're moving away from those acute issues, the ones that might be reversible, into the realm of chronic, progressive conditions. These fundamentally change how we provide daily care. We'll begin with a really functional definition. Cognitively impaired. Basically, this just means the resident is having problems with memory, thinking, or judgment. It's a broad term.
Yes, but while the term is broad, its application on the headmaster exam is laser focused. This is a massive area, and it's less about reciting the definition and much more about the intervention, especially during activities of daily living, ADLs. For a resident who is cognitively impaired, the test absolutely wants to confirm, the single most important strategy.
Right.
And that is breaking tasks down into smaller, simpler steps. That's the high miss alert right there.
Breaking tasks down. That's the core takeaway. Okay, let's make this really concrete. Give us a scenario. Let's say the task is getting dressed. If I, as the NA, use a complex command, what might that sound like, and why is it wrong?
Okay, a complex command involves multiple actions or requires decision-making they can no longer handle easily. So something like, okay, Mr. Smith, go into your closet, find a warm sweater, and put it on so we can go down to breakfast. That's way too much. The cognitive impairment makes sequencing, figuring out the order of things, really difficult, maybe impossible. It just leads to frustration, maybe anxiety for both of you.
Right. So the correct approach, the simple step intervention, the thing that's highly testable, is about simplifying everything, the language you use, the visual cues, the whole process.
Exactly. You break that task, getting dressed, into single, concrete steps, manageable chunks. Step 1, maybe you lay the clothes out first in the order they actually go on the body. Underwear first, then socks, then pants, then shirt. Step 2, you hand them just the first item. Here's your sock, put on this sock. And you wait patiently for that step to be completed. Step 3. Hand them the second sock. Wait again, step 4. Okay, now let's put your arm into this sleeve. You use very simple, direct language for each microstep. By using this method, the sequential, simple instruction, you're actually enabling them. You're helping them succeed and maintain as much self-care as possible, which is vital for their dignity.
And that principle, breaking down complexity, it applies to pretty much everything, doesn't it? Feeding, bathing, grooming.
Yeah.
If you simplify the task, you lower the anxiety and increase the chance they can participate.
Precisely. You're essentially acting as the guide. You provide the structure and the sequence that their brain, unfortunately, can no longer reliably create on its own.
Okay, good. Now let's define the big umbrella term itself, dementia. The definition is a group of symptoms. Keyword there is group. It's not one single disease that negatively affect memory, thinking, and social abilities. And crucially, these effects are severe enough to actually interfere with their daily life.
Yes, and probably the most critical fact to hammer home for test preparation is this. Dementia is not a normal part of aging. It's not inevitable. That's a fundamental distinction you have to understand. Yes, the risk goes up as we get older, but dementia itself is caused by actual damage or changes happening in the brain. The test absolutely expects you to know that there are many causes beyond the most famous one, Alzheimer's, for example. Vascular dementia, that often results from a series of tiny strokes cutting off blood flow to parts of the brain. Or Lewy body dementia, which involves these specific protein deposits that affect thinking, movement, even sleep. Parkinson's can also lead to dementia.
And the diagnosis process itself is relevant context too, right? Because it involves ruling out other things that could be causing the symptoms, things that might be reversible.
Absolutely. You mentioned things like CT and MRI scans earlier when we talked about confusion. Those imaging tests are important here too. They help rule out things like, say, a brain tumor or evidence of major strokes. Doctors also look for other reversible causes, maybe thyroid problems, certain vitamin deficiencies, even side effects from medications that can mimic dementia symptoms. Diagnosis is often a process of exclusion. Once those other possibilities are ruled out and maybe brain imaging shows certain patterns like atrophy or specific types of damage, then a diagnosis of a specific type of dementia, like Alzheimer's, becomes more likely.
Which brings us right to it. The most common cause of dementia, and arguably the most devastating one, Alzheimer's disease, AD. The definition really centers on those progressive brain changes we hear about, specifically tangled nerve fibers, neurofibrillary tangles, and those protein deposits called amyloid plaques. These build up and damage and eventually kill brain cells.
Yeah, and we really need to review the hard truths about AD because they fundamentally shape the context for the care you provide as an NA. Alzheimer's is progressive. That means it gets steadily worse over time. It doesn't plateau or get better. It's degenerative, meaning the brain tissue continues to deteriorate. And as of now, it is irreversible. There's no cure. The time frame is also really variable. From the time symptoms start until the end of life, it could range anywhere from, say, 4 years to maybe 20 years. Every single person progresses differently.
And the statistics are just staggering. We know that over half, more than 50% of all residents in long-term care facilities are living with Alzheimer's or related dementia. This is likely going to be your primary patient population in many settings.
Exactly. Which means the high-yield test alert, especially relating to the early stages of AD, centers on encouragement. While forgetfulness is often the earliest sign you might notice, the NA's role is absolutely crucial in encouraging that resident to keep doing things for themselves. Keep performing self-care, stay socially engaged, keep moving physically for as long as they possibly can. You're preserving their function, their independence, their dignity. Your role is to help them do the task, not just jump in and do it for them. That's person-centered care.
And the central symptom, the one everyone associates with AD, is severe memory loss. That forgetting of names, faces, recent conversations, important life events.
Right. And memory loss requires very specific communication techniques from the NA, especially when you're dealing with something called perseveration. Perseveration, that's the behavioral symptom where a resident gets stuck. They might repeat the exact same question over and over and over, or repeat the same action, like folding a napkin endlessly.
Oh yeah, this is incredibly challenging for staff. Just the sheer exhaustion of answering the same question for the 10th time in an hour. What is the tested, required strategy for handling perseveration?
The required strategy boils down to two things: extreme patience and absolute consistency. You must answer the question each time they ask it. And critically, you need to use the same exact words and phrases every single time. Don't try to re-explain or get creative. That consistency, even though it feels repetitive to you, provides a tiny, temporary anchor of stability for them in their very confused world. So if they ask, "When is my daughter coming?" for the 10th time, your response needs to be calmly and clearly, "Your daughter, Sarah, will be here after dinner," every single time. Don't elaborate, don't argue, don't show frustration.
That's a really subtle but vital point. You're not arguing, you're just validating the underlying concern by providing that consistent answer. Okay, what about if the resident is struggling to find a word? Maybe they're pointing at their fork but calling it a spoon.
Good question. If they're clearly struggling, like searching for a word and getting frustrated, maybe pointing at their water glass and stammering, you can gently suggest the correct word. You might calmly say, "Are you looking for your water?" But, and this is important, if they use an incorrect word confidently, like calling their shirt a jacket, you absolutely avoid correcting them. Let it go. Getting the word right is way less important than maintaining successful, low-stress communication. Correcting them in that situation usually just increases their frustration and yours.
Okay, let's transition now into some really critical high-yield behavioral terms. These are things you absolutely have to master for the exam because they come up in scenario questions all the time. Let's start with that challenge that often happens later in the day, sundowning. The definition is that increase in confusion, restlessness, or agitation that occurs specifically in the late afternoon or as evening approaches.
Yeah, sundowning. It's thought to often result from a combination of things, maybe cumulative fatigue from the day, possibly the drop in natural light messing with their internal clock, or just disruption in routine. If the test gives you a scenario involving sundowning, they are definitely looking for interventions that create predictability and, above all, calm.
Okay, lay out those high-yield strategies for us. If we know a resident tends to experience sundowning, what should the NA be doing proactively or reactively to manage it?
All right, number one, maintain a daily exercise routine. Physical activity is great, but make sure that activity happens earlier in the day. Avoid strenuous exercise in the late afternoon or evening. Second, try to avoid stressful situations or demanding appointments late in the day if possible. Keep things low-key as evening approaches. Third, and this is probably the most important one, set and stick to a consistent, calming bedtime routine. Routine is everything.
Can you give some examples? What does a calming routine actually look like in practice?
Sure, it could involve several things. Maybe limiting caffeine intake, no coffee or cola after, say, mid-afternoon. Perhaps offering a gentle back massage. Playing some soft, familiar music they enjoy, maybe reading aloud from a comforting book or looking at photos together. The environment itself should become calmer. Dim the lights, reduce noise, make things predictable. The ultimate goal, especially once sundowning symptoms start to appear, is distraction and soothing. You're trying to gently reroute their focus away from that rising anxiety that often builds as daylight fades.
Okay, that makes sense. Predictability, calm, routine. Got it. Next up, a term that represents a really fundamental shift in dementia care philosophy, and it's very frequently tested. Validation therapy. The definition here is crucial. It means accepting the resident's reality, their perspective, even if it's not factually accurate, in order to connect with them emotionally and calm them down. You're not forcing your reality or the facts onto them.
This is huge. Arguably one of the most tested therapeutic concepts in dementia care. Why? Because it directly tests your empathy and your understanding of person-centered care. The why behind it is essential to grasp. If you try to argue facts with someone whose memory and reasoning are damaged by dementia, you're basically forcing a confrontation their brain can't handle. It's almost guaranteed to cause frustration, maybe anger, sometimes even what we call catastrophic reactions. Validation, on the other hand, preserves their dignity. It meets the underlying emotional need behind their words or actions, even if the words themselves aren't true.
Okay, let's nail the classic exam scenario for this. A resident is repeatedly asking to go home to see her mother, but her mother passed away 20 years ago, and this facility is her home now. What's the tested incorrect response? And what is the correct validation therapy response?
Right. The incorrect response, the one that confronts and corrects, would be something like, "Your mother died years ago, Mrs. Davis. You live here now. This is your home." That's likely to cause instant distress, confusion, maybe tears. The correct response uses validation therapy. It acknowledges the emotion behind the words. You might say something gentle like, "It sounds like you really miss your mother very much," or "Tell me about your mother, what was she like?" Or even, "Tell me about your home, what did you like best about being there?" You explore the feeling, validate that emotion.
So you connect with the feeling, draw them out about the memory or emotion, validate it,
Yeah.
and then what? You gently redirect, right?
Exactly. After you validated that feeling, it sounds like home was a wonderful place for you. Then you gently redirect their attention to a pleasant, engaging activity in the present. Like, "Why don't we go look at these beautiful flowers?" Or, "Could you help me sort this basket of colorful yarn?" You shift the focus smoothly.
Okay. And just briefly, how does this differ from, say, reminiscence therapy? That's another term we sometimes hear.
Good distinction. Reminiscence therapy is also valuable. It involves encouraging residents to talk about past events, happy memories, actual experiences from their lives. It's like therapeutic storytelling about things that really happened. Validation therapy is specifically about engaging with their current emotional reality, even if that reality is based on a false belief or memory. Both can be useful, but validation is the go-to for reducing acute distress caused by disorientation or confusion about the present. Activity therapy, just using meaningful activities, is another tool in the box.
All right, let's shift back to practical management vocabulary, handling those really difficult scenarios. Let's talk about the confused resident who is maybe insisting on doing something unsafe or not allowed, like maybe trying constantly to leave the facility, or perhaps bothering other residents in the dining room.
Right. The key tested strategy here, you could almost call it the rule of three. Limit how often you say don't, stop, or no. Those words often act like fuel on the fire. Instead, your primary tool is immediate, gentle, and repeated redirection. You have to guide them away from the unsafe or inappropriate activity before it escalates. Distract and redirect.
Okay, so give me an example. A resident is rattling the handle of a locked, secure exit door, clearly wanting to leave. What does redirection look like in that moment?
You wouldn't just say, don't do that. You'd approach calmly, maybe gently take their arm and say something like, oh, Mr. Johnson, let's walk this way instead. Look, the activity room is setting up for music. Can you come help me carry these songbooks down the hall? You substitute a safe, preferably enjoyable alternative activity for the unsafe one. The goal is always to keep their mind and body occupied in a positive, safe way.
What if the behavior escalates? What if the resident becomes verbally abusive, using terrible language, maybe yelling hateful things directly at the NA? This is incredibly hard to deal with in real life.
It is incredibly difficult, and this situation directly tests your professional composure and, crucially, your understanding of the disease process itself. You have to internalize this mantra, repeat it to yourself. It is the dementia speaking, not the person. The tested intervention is to remain calm. Avoid making direct eye contact if that seems to escalate the situation for them. And as hard as it is, ignore the language. Do not take it personally. Don't argue back. Your focus remains on safety and redirection. Try to redirect their attention to a different task, or perhaps gently guide them to a quieter environment if possible. Your empathy and professional distance are absolutely critical here.
That's tough, but essential advice. Okay, our final cluster of behavioral challenges centers on the demanding resident. This might be someone who constantly repeats requests, perhaps shows sudden irritability, seems very anxious. What's often going on underneath that?
Often, maybe even usually, that demanding behavior is rooted in an unmet need. They might be hungry or thirsty. They might be in pain but can't articulate it well. They might need to use the toilet. Or it could simply be anxiety or confusion driving the repetitive requests. Your first step is always to try and figure out if there's an underlying physical need or discomfort. Check if they need the bathroom, offer a drink, see if they seem pained.
Okay. And this idea of unmet needs or triggers leads right into managing related difficult behaviors. First up, catastrophic reactions. These sound serious.
They are. A catastrophic reaction is a sudden, intense, emotional outburst. It seems way out of proportion to whatever just happened. We're talking sudden crying, maybe hitting or kicking, screaming, a complete meltdown.
What typically causes these? And more importantly, how can NAs try to prevent them?
They're almost always triggered by something. Common triggers include feeling overwhelmed by too much stimulation, like a noisy, crowded room. Fatigue is a big one, being asked to make difficult or complex choices. Or, again, underlying pain or discomfort. Prevention is all about being proactive. Maintain that predictable routine. Avoid overly busy or noisy environments, especially if you know the resident is sensitive. Keep choices very simple. Instead of, do you want chicken, fish, or pork for dinner? Maybe just offer, would you like the chicken tonight? Don't force them. Now, if a catastrophic reaction does happen, the NA's immediate action is crucial. Remove the trigger. If the noise is the problem, gently guide them out of the room. Then distract them immediately with something familiar and soothing. Calm reassurance is key.
Okay. Let's talk about two other challenging behaviors that often go together. Rummaging and hoarding. This can cause real friction, especially if they're going into other residents' rooms.
It definitely can. But the absolute crucial point for the NA to remember, and this is vital for the test and for compassionate care, is that a person with Alzheimer's cannot steal. That concept is gone for them. They're experiencing a loss of understanding about object permanence, about ownership. Rummaging, searching through things, and hoarding, collecting items, often seemingly random ones, are symptoms of the disease. They're often driven by an internal need to search for something familiar, something comforting, or maybe something they feel they need from their past.
So punishment or scolding is completely inappropriate. What are the tested, respectful NA interventions to manage rummaging and hoarding?
It's all about management, safety, and redirection, not punishment. First, make sure their own important belongings are clearly labeled. That helps minimize confusion. A great strategy, often mentioned, is placing a unique, easily recognizable label or symbol on the outside of their room door. This helps them identify their own space. And probably the most practical, high-yield intervention you'll see tested is providing a dedicated rummage drawer or rummage box. This is a specific place, maybe a drawer in their dresser or a box on a shelf in their room that you fill with safe, interesting items they can handle, sort through, fold, or examine. Things like old keys, soft fabric squares, junk mail, old wallets without money. This gives them a safe outlet for that rummaging urge, satisfying the need in a controlled, non-disruptive way.
That's a fantastic practical tip. Provide a safe space for the behavior. Okay, since we've touched on ADLs throughout, let's just quickly recap some specific care guidelines, say for grooming and nutrition, that really tie back to managing these cognitive impairments.
Definitely. For bathing and grooming, timing can be key. Try to schedule bathing for the time of day when the resident is typically least agitated. For many, that's earlier in the day. Definitely not during those potential sundowning hours in the late afternoon or evening. Always, always provide maximum privacy. Keep the process super simple, breaking it down into those small steps we talked about. And let the resident do as much as they possibly can for themselves, even if it's just holding the washcloth. Encourage independence.
And for nutrition, mealtimes. Simple environment is the mantra there too, right?
Absolutely non-negotiable. Mealtime needs to be calm, simple, and relaxed. Remove distractions, turn off the TV, try to seat them away from busy hallway traffic if possible. Use plain, simple plates. Sometimes using plates that contrast in color with the food helps them see it better. Maybe only put one food item on the plate at a time to prevent them feeling overwhelmed. And just like with dressing or bathing, breaking the act of eating into clear, simple instructions might be necessary. Pick up your spoon. Wait, now take a bite of potatoes. Wait. Patience and simplicity are everything. #outro.
Wow, okay. We have really unpacked a lot of essential vocabulary for Chapter 5 today. We've linked terms like confusion, Alzheimer's, sundowning, validation therapy, and even things like catastrophic reactions directly to those testable scenarios and the required NA interventions you need to know.
Yeah, we covered a lot of ground. Your final study tip for this whole chapter, I'd say focus relentlessly on those care guidelines. They really are the direct, practical application of all this terminology. Remember those core principles. Consistency helps maintain routine, encouragement promotes self-care and dignity. And simple, clear, consistent communication is absolutely the key to managing challenging behaviors effectively. If you can understand the why behind the intervention, why validation works, why breaking down tasks is crucial, that's what will really help you analyze and ace those application questions on the Headmaster Test.
Definitely. Now, before we sign off, here's something provocative for you, our listener, to consider as you study this chapter and think about your future career. We know, tragically, that people living with Alzheimer's disease and other dementias are uniquely vulnerable. They're at a higher risk for abuse and neglect, partly because their cognitive impairment often prevents them from reporting it clearly. So as you prepare for your test, think specifically about the daily care tasks we've discussed, the ADLs. Which crucial observation, tied either to something like hydration and nutrition or perhaps skincare, might serve as the most immediate and critical physical sign of potential neglect that you, as an NA, absolutely must report to the nurse right away. And think about why that constant vigilance over these sometimes subtle physical signs is so incredibly vital in a population that often cannot advocate for itself. Something to really mull over. That's all for this deep dive into Chapter 5. Stick around for the next chapter of our Key Terms Test Prep series. Welcome to Part 6 of our Key Terms podcast series for the Headmaster Test Prep. There are 10 parts total, one for each chapter. Stick with us to ace your exam. Today, we are undertaking a critical deep dive into the essential vocabulary for personal care skills, Chapter 6. So if you're, getting close to sitting down for that written Headmaster exam, this is really what you need. We're not just going through definitions. We're aiming to connect these key words, the ones that show up again and again on the test.
Especially those tricky ones, the high miss rate ones.
Exactly. We want to link them to real-world procedures, those safeguards you absolutely need to know. Our goal today is really to make these concepts stick so they're right there in your memory when you're under pressure in the exam.
And personal care, well, It's really the bedrock of what a nursing assistant does. I mean, you're right there, up close and personal.
Yeah.
Your actions directly impact how the resident feels, their dignity, their safety, and the exam, it knows this.
Yeah.
Which is why, the questions people fail most often in this chapter, they're about those procedural steps, the ones that protect the resident's independence and prevent injuries.
So it's not just what the rules are.
No, it's about why. The serious things that can happen if you overlook them. We need to focus on that today.
Okay, let's start right at the beginning then. The term that kind of frames this whole chapter, personal care.
Mm-hmm.
We define it simply, right, helping a resident with hygiene tasks. Bathing, grooming.
Yeah, the basics. But what's the core idea? The philosophy the exam really wants you to grasp.
What's behind the definition?
It really boils down to two big concepts, dignity and independence. When we talk personal care, the test is checking if you're committed to making sure the resident is still, an active participant in their own life.
So you're assisting, not just
Mm-hmm.
taking over completely.
Exactly. That distinction is absolutely key.
Okay, so picture a test scenario, and NA is helping with care. How do we show we understand dignity in that situation?
Well, it comes down to communication and definitely respect for privacy. You've got to provide privacy, always.
Closing the door, pulling the curtain.
Right. Using a screen if you need to.
Yeah.
But just as important, maybe more so, is explaining exactly what you're doing before you even start.
Like saying,
Like, okay, Mrs. Jones, I'm going to turn you toward me now so I can wash your back. Simple as that. It treats them like a person, acknowledges them, doesn't just make them feel like an object being handled.
that makes sense. And what about the environment? Specific actions related to the room that show independence and safety, especially if the NA has to leave. Maybe just for a second.
Oh, there are two absolute non-negotiables here. You see these pop up all the time in procedural questions on the test.
Okay, what are they?
First, always return the resident's bed to the lowest possible position.
Critical fall prevention.
Absolutely critical. And second, the call light. It must be securely placed where the resident can easily reach it, no question.
So even if you just step out for supplies or when care is done.
Yep. Those two steps ensure the resident still has some control, and they can get help immediately if needed. Missing either one, that's a huge safety fail on the test and in practice.
Wow, it really ties independence directly to their physical safety.
It does.
Now, beyond the room setup, the materials really hammer home observation during personal care. What should we be looking for while we're, say, washing someone or helping them groom?
Right. This is where care and assessment really blend together. You're not just washing, you're observing, collecting data, really.
So what kind of data?
You have to report any changes you notice in their physical state. That could be a new rash, maybe skin tears, or if they suddenly seem to be in pain when you touch a certain area.
Physical signs? What else?
Also, their mental state. Are they more confused today? More anxious? Or maybe they're unusually quiet, withdrawn? Personal care gives you this unique window into their overall health.
Things a nurse might not see otherwise.
Exactly. You're the eyes and ears on the front line during these intimate moments.
Okay, good point. Let's shift to some specific tasks now, starting with hair care and grooming.
Mm-hmm.
Hair care, washing, brushing. Pretty straightforward for hygiene and comfort.
Mm-hmm.
But you mentioned dignity earlier, and there's a rule here that's apparently a common mistake.
Yes, there is. When you're helping, you absolutely must let the resident choose their own hairstyle if they're able to.
Makes sense.
The critical error, the one the test flags, is styling their hair in a childish way.
Like pigtails on an elderly woman.
Exactly. Unless she specifically asks for it and it's documented, don't do it. It diminishes their self-image. It violates their dignity. We have to treat residents like the adults they are, always, even during simple tasks like brushing hair.
Got it. Treat them like adults. Now let's pair that with shaving, safely removing facial hair using cream and a razor.
Yeah.
Before we get into the equipment rules, what's the absolute basic safety step here?
Gloves. Always wear gloves when shaving a resident. It's a standard precaution.
Okay. And with a disposable or safety razor?
You'd apply shaving cream usually to soften the hair first, then shave in the direction the hair grows.
Why that direction?
It just prevents discomfort, reduces the chance of little cuts or ingrown hairs, makes it smoother.
Okay. Now the big one. The high-stakes test question about equipment. If you use an electric razor, what's the life-saving rule? The one with 0 exceptions.
Right. You cannot use an electric razor near water, period.
Okay, water's one.
And also, critically, near any oxygen equipment.
Ah. Why is that?
Well, you're basically preventing two potential disasters. First, electrocution, obviously, if the razor hits water.
Right.
Second, fire. If there's an electrical spark from the razor near concentrated oxygen, that's an immediate fire risk. It's incredibly dangerous.
So a resident on oxygen.
Should never be shaved with an electric razor. Use a safety razor instead. It's a zero-tolerance safety rule.
That is a crucial safety point. Okay, let's shift focus now, moving to an area that's fundamental for preventing major problems. Foot care.
Very important.
The definition is washing and carefully checking the feet. And the prep materials really stress this for residents who are diabetic or have poor circulation.
Yeah, this is a critical procedural safeguard. For someone with diabetes, even a tiny cut or blister on their foot, it can turn into a serious infection really fast.
Because of poor circulation and slow healing.
Exactly. The risk is genuinely profound. Amputation is a real possibility from what starts as a minor foot issue.
Wow. Okay, so the definition seems simple, but the procedure is where people mess up on the test.
Often, yes. There's one key step in drying the feet that gets missed.
And that is?
You have to make sure you thoroughly dry between the toes.
Between the toes. Why is that so critical?
And any moisture left there creates this perfect little environment for fungal infections or skin maceration. That's when the skin gets too soft and just breaks down easily.
So that small step prevents the skin from breaking open, becoming non-intact.
Precisely. It's a simple thing, but vital.
Speaking of non-intact skin, quick tip time. What's the very first thing you should report to the nurse if you see it on a resident's foot?
Any sign at all of non-intact or broken skin, report it immediately.
Like a blister, a cut, an open area.
Yep. Any of those need a nurse to look at them right away. But you also need to report other things you observe.
Such as?
Look for heels that seem soft, fragile, or maybe red. Check if one foot feels much colder or hotter than the other. That difference in temperature is a big red flag.
Could signal circulation problems?
Severe ones, potentially. Also report any drainage or blisters, of course.
Okay, let's use foot care as a bridge here. Talk about broader skin integrity principles. We're not defining pressure injuries specifically today, but the guidelines for preventing them are all over Chapter 6, right?
Absolutely central. Prevention is key. So NAs need to be constantly vigilant, whether they're bathing someone or just helping them reposition.
What are we looking for? What are the early warning signs?
Look for skin color changes, especially over bony spots, heels, hips, elbows, the tailbone. Is the skin pale, white, reddened, maybe gray, or even purplish?
And what if you see a spot like that?
If you press on it gently, does it blanch? Meaning, does it turn white for a second and then return to red? If it doesn't blanch, if it stays red, that's a bad sign. It suggests potential tissue damage underneath the surface. Report that immediately.
Okay. And preventative actions.
Yeah.
Two big ones related to friction and pressure relief that the test loves.
First one is time. You absolutely must reposition residents who are bedbound at least every 2 hours, minimum.
2 hours for bedbound. What about in a chair?
If they're in a chair or wheelchair and can't shift their own weight effectively, it's even more frequent. Reposition them at least every hour. And you have to document it.
Documenting the turn or repositioning is key.
Yeah.
Okay, what's the second big rule? Something you should not do.
Never, ever massage bony areas, especially if you see that white, red, or purple discoloration we just talked about.
Why not? Seems like massage would help circulation.
It seems counterintuitive, but massaging tissue that might already be damaged can actually cause more injury deeper down. It can break down fragile capillaries. So no massage on those pressure-prone spots.
Got it. No massage on bony spots. Now, that brings up a tricky concept. Shearing. How's that different from just regular friction?
Okay, friction is pretty simple. It's skin rubbing against a surface, like dragging someone across a sheet.
Okay.
Shearing is nastier. It happens when the skin sticks to the surface, say, the bed sheet, but the person's bones and the tissues underneath move downward, like when the head of the bed is raised and they slide down.
So the skin stays put, but the inside slides.
Exactly. And that causes the layers inside muscle, fat, connective tissue to literally tear away from each other and from the blood supply. It leads to deep tissue damage, pressure injuries.
Ouch. So how do we prevent that? You mentioned sheets earlier.
Keeping the bottom sheet completely tight and wrinkle-free is crucial. A wrinkle basically acts like a little ridge that increases that shearing force.
Makes sense.
And we also use lift sheets or turning sheets and proper lifting techniques. Never drag a resident up in bed. Lift them. It minimizes both friction and that dangerous shearing force. It's all about protecting that skin integrity.
Okay, really important distinctions there. Let's move into the actual bathing procedures now. This is where safety and technique really merge. Bathing, basic definition. Washing the body for cleanliness. What's the absolute first safety check before anyone even touches the water?
Water temperature. Always. It's your first line of defense against burns.
How do you check it?
You have to use a bath thermometer if available, or test it carefully with the inside of your wrist. And ideally, let the resident check it too, if they can. Ask them, does this feel comfortable?
And what's the safe temperature range generally?
Generally, around 105 degrees Fahrenheit is considered safe and comfortable. Too hot, obviously, risks burns. Too cold, and the resident might get chilled, rush the bath, maybe slip, or just refuse care next time.
Right. Now, technique. To prevent spreading germs, what's the rule for the order of washing? And when do you need to change the bath water?
Okay, the rule is always wash from the cleanest areas to the dirtiest areas. Always.
Cleanest to dirtiest.
Yeah.
So typically starting with?
Usually the face, then arms, chest, abdomen, legs, and then you do the back. Perineal care is last. This prevents spreading bacteria from, say, the anal area to the rest of the body or the face.
And changing the water.
You absolutely must change the bath water if it gets too cool or if it gets visibly dirty or too soapy. And definitely, if you're doing a full bed bath, you need fresh water and fresh gloves before you start perineal care. Clean basin, clean water, clean gloves.
Okay. Now, the source material breaks down a few types of baths. First, the bed bath. That's washing someone completely in bed if they can't get up. This seems like a time when you might do other things too.
Yeah, a bed bath is usually pretty comprehensive. It's often the perfect time to bundle other care, like giving a nice back rub, good for circulation and comfort. Or doing nail care, maybe even shampooing their hair in bed if needed. It's efficient and it maximizes comfort for the resident.
Makes sense.
Then.
Next type. The tub bath.
Ah.
Soaking in a tub for a full cleaning. You mentioned earlier this term, or the procedure, has one of the highest failure rates on the exam. Why is that?
It comes down to one single, absolute zero-tolerance rule for resident safety.
Which is?
Never leave the resident alone during a shower or a tub bath. Ever. Under any circumstances. Don't step out. Don't turn your back for more than a second.
Why is that so critical?
Falls in the bathroom are incredibly common, and they can be devastating. Plus, if a resident starts to feel faint or has a medical emergency, you have to be right there to help immediately. Leaving them alone is considered abandonment and a critical safety violation. Automatic fail.
Okay, that rule is crystal clear. Never leave them alone.
Yeah.
What else, besides being present, do we need to ensure for a safe tub bath?
Well, preparation is key. Make sure the path to the tub is clear and dry. Use any required assistive devices like transfer benches or grab bars correctly. Have everything you need. Soap, washcloths, towels, within easy reach before the resident gets in. If they can wash themselves partially, make sure they can reach what they need.
Any practical tips?
Yeah, avoid using bath oils or heavy lotions in the water. They make the tub surface incredibly slippery, really increasing that fall risk. And make sure the floor stays as dry as possible.
Good point. Okay, third type. The sitz bath. This one sounds specific. What's its purpose?
Yeah, sitz bath is very targeted. It's not a full body wash. It involves just sitting in warm water that covers the perineal and rectal area.
And why would someone need that?
It's usually prescribed to soothe that area, maybe after rectal surgery or childbirth, or if the resident has hemorrhoids or significant irritation down there. The warm water helps with healing, reduces pain, and improves circulation to the area.
Okay, targeted soothing.
Yeah.
That leads us perfectly into perineal care. Cleaning the genital and anal areas. This is another high miss area focused on technique.
Yes, and the mistake here is usually the wiping direction. Getting this wrong has serious consequences.
What's the rule?
For females, you always wipe front to back, from the urethra towards the anus. Always.
And the reason is?
To prevent urinary tract infections, UTIs. Bacteria from the anal area can easily be transferred to the urethra if you wipe the wrong way, causing infection. UTIs are a major health risk for elderly residents.
So front to back, how does the whole procedure flow?
You start cleaning the cleanest part, the urethral area, and move backward towards the rectum. Critically, you need to use a clean part of the washcloth for every single wipe.
Every wipe, a clean spot.
Yes, or use a fresh disposable wipe for each stroke. Fold the cloth or grab a new wipe. After cleaning the front, you gently turn the resident onto their side to clean the anal area.
And you have to be careful not to.
Right, careful not to recontaminate the front area you just cleaned when you turn them back. And throughout this whole process, maintaining privacy and dignity is paramount. It's a very sensitive procedure.
Absolutely. What if, during perineal care, you notice something unusual, like a rash or discharge or maybe an odor?
Report it to the nurse immediately. Don't just keep cleaning. Any sign of infection, skin breakdown, irritation, or any unusual discharge needs a nursing assessment right away.
Got it.
Yeah.
Immediate reporting. Okay, let's move back up to the head now. Focus on oral hygiene and mouth care. Oral hygiene is sort of the general practice, keeping the mouth clean. Mouth care is the actual task, brushing teeth, tongue, gums, or cleaning the gums if they have no teeth. What's the standard frequency for this? How often should it be done?
Standard care is at least twice daily, morning and evening typically, or more often if needed or requested.
And why is it so important?
It prevents plaque buildup, which leads to cavities and gum disease. It also prevents mouth infections, which can actually surprisingly affect overall health, like contributing to pneumonia or heart issues. And it helps maintain appetite and comfort.
Okay. Now, observation again. What are the red flags we need to look for and report during mouth care? The test might give scenarios here.
Right, observation is huge. You're looking for any irritation, maybe sores or ulcers in the mouth. Are the gums red, swollen, bleeding? Is the tongue coated or swollen?
Anything else specific?
Yes. Two things in particular need immediate reporting. First, any flaky white spots. Could be thrush, a yeast infection.
Okay, white spots. What's the second one?
Bad breath is one thing, but also, kind of surprisingly, fruity breath.
Fruity breath. That sounds odd. Why is that a red flag?
It sounds harmless, but fruity-smelling breath can be a really serious sign of diabetic ketoacidosis, or DKA. It's a life-threatening emergency for people with diabetes.
Wow, how does that happen?
It means their body isn't using sugar properly and is breaking down fat for energy instead, releasing ketones, which have that sweet, fruity smell. It requires urgent medical attention. So yeah, even a smell needs reporting.
That's a great example of why observation is so critical. Okay, let's talk about the riskiest situation for mouth care. The unconscious resident. The main danger here is defined by the term aspiration.
Exactly. Aspiration means inhaling something into the lungs that shouldn't be there. Food, liquid, saliva, even vomit.
And the consequences.
Can be really severe. It can cause choking, obviously, but also aspiration pneumonia, which is a lung infection that's often fatal, especially in frail residents. The risk is highest when doing oral care on someone who can't control their swallow reflex because they're unconscious or semi-conscious.
So the technique to prevent aspiration in an unconscious resident is absolutely vital. What are the two mandatory steps?
Mandatory steps. First, use very little liquid. If you're using swabs, make sure you squeeze out any excess liquid before you put them in the resident's mouth. Minimize the fluid.
Okay, minimize liquid. What's the second crucial step?
The absolute must-do safety step is to turn the resident onto their side. Position them in a lateral position.
Why does that work?
Simple gravity. It allows any fluids, saliva, or the cleaning solution to drain out of the mouth down onto the towel you've placed instead of pooling in the back of the throat where it could be inhaled into the lungs. It's a fundamental safety measure.
Turn them on their side.
Yeah.
Okay, next term. Denture care. Cleaning false teeth daily. You mentioned handling and storage are high-risk areas. Dentures are expensive, fragile.
Very fragile, very expensive.
What's the critical temperature rule that people often forget?
The rule is never use hot water to clean dentures. Never.
Why not?
Dentures are usually made of acrylic or specialized plastics. Hot water can warp them, make them change shape.
And if they warp?
They won't fit properly anymore. They can cause sores, make it impossible to eat comfortably, and then they need to be replaced, which is costly. So always use cool or lukewarm water.
Okay, cool or lukewarm water only. What about handling them safely when they're out of the mouth?
Right, you need to wear gloves, of course, and handle them very carefully. They can slip easily.
So to prevent breakage.
Good practice is to line the sink basin with a washcloth or paper towels, or fill the sink partway with water before you start brushing them. That way, if you do drop them, they land on a soft surface, not hard porcelain.
Smart. And storing them.
Usually overnight, they should be stored safely in a labeled denture cup, filled with cool water or a denture-soaking solution. Or if the resident prefers, clean them and give them right back. Just make sure they're stored safely and moist.
Okay, let's quickly connect back to aspiration with the definition of dysphagia.
Right. Dysphagia simply means difficulty swallowing.
So if a resident has dysphagia,
Their risk of aspiration, inhaling food or liquid, is much, much higher. You have to be incredibly careful during any feeding and during mouth care.
what does that mean practically?
It means you need to know their care plan. They might need special diets like thickened liquids or pureed foods. They'll likely have specific positioning requirements, maybe sitting fully upright during meals, and even for mouth care, to minimize that aspiration risk. Extra vigilance is needed.
Okay, good connection. Let's move into our last main section, dressing and elimination. Starting with dressing, assisting a resident with clothes. You said this is maybe the most common high-miss area on the test.
It really is. Because of the very specific sequence you have to follow, especially for residents with weakness or paralysis on one side, maybe from a stroke.
And the whole point, again, is promoting their independence as much as possible.
Exactly. Even if someone has significant weakness, you encourage them to choose their clothes, to do whatever parts of dressing they can do. The test really focuses on the terminology you use and getting that sequence right.
Okay, terminology first. We should not call the weak limb the bad side.
Correct. Use professional, respectful terms. The affected side or the involved side. It sounds more clinical and maintains dignity.
Affected or involved side, got it. Now the rule, the sequence that needs to be drilled into memory. How does it go for dressing and undressing?
Okay, here's the mantra. Weak side on first, strong side off first.
Weak on, strong off. Say that again.
Weak side on first, strong side off first. When you are dressing someone, putting clothes on, you start with the weaker, the affected arm or leg. Put the sleeve or pant leg on that side first.
Why start with the weak side?
Because it's usually harder to move that limb. Getting the garment over the affected side first requires less maneuvering and stress on that limb later. Then you can easily do the stronger side.
Okay. And for undressing, taking clothes off.
You reverse it. You take the garment off the stronger side first. Then you can provide full support to the weaker side as you carefully remove the clothing from that affected limb last.
Weak on first, strong off first. Let's walk through a quick example. Mrs. P has left-sided weakness from a stroke. We're putting on her shirt.
Okay, so you'd get the clean shirt ready. You would gently guide her left arm, the weaker, affected arm into the left sleeve first. Get that part done. Once her left arm is through, you'd bring the shirt around her back and then have her put her stronger right arm into the right sleeve. Then finish adjusting the shirt.
That makes sense. Maximizes comfort for the left side.
Exactly. Minimizes strain.
Now, what about advanced dressing? Specifically, a resident with an IV, an intravenous line. This seems tricky and high risk.
It is. There are very specific rules here. 2 absolute non-negotiables regarding the IV equipment itself.
Okay, what are they?
Rule number 1. You never, ever disconnect the IV tubing for any reason.
Never disconnect. Rule 2.
You never turn off the IV pump if one is running. Messing with the flow rate or stopping the infusion is outside your scope of practice and can be dangerous.
Okay. One more thing about the IV setup.
Yes, you always have to make sure the IV bag or bottle stays higher than the insertion site on the resident's arm or hand. Gravity keeps the fluid flowing correctly.
Right. Keep the bag high.
Yeah.
Now, the actual dressing procedure with an IV.
Okay, when undressing, taking the gown off, you remove it from the arm without the IV first. The non-IV arm comes out first.
Okay.
Then you carefully slide the sleeve down the arm with the IV, over the tubing and the site, and off the arm. Then lift the gown off the IV pole.
And putting a clean gown on.
You start with the arm with the IV, carefully slide the clean sleeve over the IV bag, then the tubing, and onto the resident's arm, making sure the tubing isn't kinked and the IV site is okay.
Then hang the IV bag back up on the pole immediately. Then put the other sleeve on the non-IV arm. It takes care and patience.
Definitely sounds like it requires focus. Okay, shifting to elimination needs. 2 types of pans mentioned. The standard bedpan, used by residents in bed, and the fracture pan.
Right. The fracture pan is a really important piece of equipment. It's different from a standard bedpan. It's shallower, flatter, and has a handle.
And it's used specifically for
residents who can't lift their hips very high.
Yeah.
Typically, someone with a recent hip fracture or maybe hip replacement surgery or someone with severe arthritis or other mobility limits. The standard pan might be too high and painful for them.
Okay. And the placement is different too, right? That's key for the test.
Yes, placement is key. A standard bedpan goes under the resident with the wider curved end aligned under their buttocks. A fracture pan is positioned differently. The handle points towards the foot of the bed. The flatter lower end slides under the buttocks. Handle towards the feet for the fracture pan. Got it. And we need to remember, assisting with elimination. It's a very vulnerable time.
Absolutely. Probably one of the most vulnerable moments for a resident. So dignity is crucial. Provide privacy immediately. Pull the curtain. Cover them appropriately.
And respond quickly.
Respond quickly when they call. Don't leave them sitting on the pan longer than necessary. Clean them thoroughly and gently afterward. Help manage any odors. It's all part of providing respectful care.
Okay. We also have the emesis basin defined here.
Yeah, the emesis basin, that's the kidney-shaped plastic pan.
Primarily for
Primarily used if a resident feels nauseous and needs to vomit to catch the emesis, but it's also commonly used during mouth care for the resident to spit rinse water into.
Right. Handy little basin. Lastly, in this section, the term specimen. A sample, usually urine or stool, collected for lab tests. This is a high-miss area because of the collection procedure, specifically for urine.
Yes, exactly. When you need to collect a urine specimen, the guideline you absolutely must follow is to get a midstream urine sample, often called a clean catch midstream sample.
Midstream. What does that mean, practically?
It means you have the resident start urinating first into the toilet or bedpan, just a little bit.
Okay, start voiding.
Then you have them stop the flow momentarily, if possible. You place the sterile specimen container under them to catch the middle part of the urine stream.
Catch the middle part.
Right. Then, before they finish emptying their bladder, you remove the container. They finish urinating into the toilet or pan.
Why go through all that? Why the middle part?
The initial stream of urine helps to flush out any bacteria or contaminants that might be lingering around the opening of the urethra. So, the middle part of the stream is considered the cleanest sample, the one that best represents what's actually inside the bladder.
So it gives more accurate lab results.
Exactly, especially if they're testing for a UTI. And then, of course, you have to cap the container immediately without touching the inside and label it accurately right away. Resident's name, date, time, room number. Proper labeling is critical.
Okay, midstream clean catch. Got it. That covers a lot of ground for elimination in specimens.
It does. Lots of procedural details there.
All right, let's try to pull this all together now in our final section. We've gone through a ton of key terms and procedures for personal care. Before we wrap up, let's quickly synthesize maybe the top critical failure points, the things that, based on test results, people most often get wrong in this chapter.
Okay, we can definitely highlight a few absolute must-knows, the things with zero room for error on the exam.
So number one, you mentioned it multiple times, that dressing and dressing sequence.
Absolutely. Getting that reversed is a super common error. You have to burn this into your brain. Weak side on first, strong side off first. Remember that mantra? It protects the resident's affected side.
Weak on, strong off. Got it. What's the second major category of errors?
I'd group together the immediate environmental and temperature safety rules, the ones that can cause instant serious harm if you forget them.
Like?
The three big ones we hit hard. 1, never leave a resident alone in the tub or shower, ever. 2, never use hot water on dentures. And 3, always, always turn an unconscious resident onto their side during oral care to prevent aspiration.
Those three are non-negotiable safety nets.
Exactly. They are red flags. Missing one of those demonstrates a fundamental lack of understanding of safety.
Okay. And a third major failure point, you see.
Forgetting that observation is not separate from the task, it's part of the task.
Can you give examples again?
Sure. If you're doing foot care, finding and reporting non-intact skin is an extra. It's required. If you're doing mouth care, noticing and reporting that fruity breath isn't optional. It's critical. If you're bathing someone, identifying and reporting a potential pressure area isn't just good practice, it's part of the standard of care.
So the procedure isn't truly complete until you've done the observation and reported anything significant.
Precisely. Observation, reporting, and documenting are integral to every personal care task.
Excellent summary. Okay, let's wrap up with our final challenge question. This links back to that core idea of independence. Remember, Mrs. S recently had a stroke, right-sided weakness. She's feeling frustrated, maybe a little depressed, and she's refusing to participate in her personal care. She just wants the NA to do everything for her, even though her care plan says she needs to do as much as she can.
Right, a common scenario.
Based on everything we've covered today, what is the primary reason the NA must encourage Mrs. S to participate, even if it takes longer, even if it's frustrating for both of them? Why can't the NA just do it all to save time?
Well, the primary reason, the core reason, is that encouraging her participation is the only way to help Mrs. S maintain whatever function she still has and hopefully prevent further decline.
It's about maintaining function.
Yes.
Yes.
Her ability to perform those activities of daily living, those ADLs like dressing or washing her face, it directly impacts her recovery process, her self-esteem, her overall quality of life.
So if the NA just takes over,
If the NA does everything for her, they actually risk making her more dependent in the long run. They risk her losing the strength and ability she still has. The NA's job isn't primarily about speed, it's about promoting the resident's highest possible level of function and independence.
that perfectly captures the why behind so many of these rules. It's not just about tasks. It's about preserving the person's ability and dignity.
Exactly.
That really brings it home.
Yeah.
All these procedural steps we discussed, locking the wheelchair brakes before you transfer someone, checking that water temp every single time, knowing how to place a fracture pan correctly, they aren't just abstract details for a test. They are the absolute essential ethical habits that form the foundation of a safe and competent career as a nursing assistant.
Absolutely. So the goal shouldn't just be memorizing for the test. Focus on mastery. Understand why these rules exist, the safety reasons, the dignity reasons. If you understand the why, you'll not only ace the exam, but more importantly, you'll provide truly excellent, safe care to your residents.
Great final thought. Focus on mastery, not just memory. Thanks for diving deep with us into Chapter 6. We hope this helps you prepare. We'll see you next time for Chapter 7.